गोरखपुर पहुंच गई, फिर मन से बोल
ठीक है, कोई भैया कुछ काम होगा तो बुलाएंगे, आ जाना। हेलो,
इसका वीडियो फिर गया शिखा का।
नीरो है, नीरो।
हाँ
हाँ निशा का आपने शुरू किया।
Ma'am, we are live now.
Good evening, respected seniors, faculties, and delegates, and a very warm welcome to this August gathering. After our successful scientific deliberations in Classic for Clinicians and Yuva Leads and Speaks webinar, we step forward to some very interesting scientific feast in the series of Yuva ISOPARB educational webinars conducted by Gorakpur chapter of ISOPARB and Gorakhpur Obs and Gynae Society under leadership of Pride of Gorakhpur and our society, Dr. Sadhna Gupta. Shall I continue?
Yes, continue.
Okay.
Please mute everybody.
Youth are the
Nisha,
kindly mute yourself. Youth are. तो वापस आ गया. Ma'am, shall I continue?
Yes.
Yes, Babita, you can continue.
Youth are the future of our society and full of innovative thoughts and ideas. They have warm blood of taking bold decisions even in difficult situations. We aim at blending the youthful ideas with years of experience of senior teachers and doctors and come out with reasonable, practical, and safe guidelines. Every auspicious occasion begins with the blessings of Vignaharta, Lord Ganesha. Let us join our hands for Ganesh Vandana with folded hands and seek the blessings of the Supreme Lord. Kindly play Ganesh Vandana. Nisha.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
I request all our esteemed faculties to join for the lighting of the lamp. Nisha, please. May this light wash away the darkness of ignorance from our lives and we all be enlightened with knowledge. And this webinar be very good. Thank you so much, Nisha. Dr. Gangadhar Sahu. We all know Sir is president of ISOPARB now. Heartiest congratulations to you, sir, for this very important post. And we all look forward to a great tenure ahead. Sir is retired professor and HOD, Obs and Gynae VSS Medical College, Burla. He is Dean IMS and some hospital, Bhubaneswar. President-elect ISOPARB 22-23, a learner, teacher, preacher, healer, administrator, and writer. an ordinary human being surrounded by extraordinary friends, well-wishers, and critics. His principle of life, never be a defaulter, and journey of life, my life is a success story. His dream is to be a ladder for others to climb to the top. What wonderful thoughts, sir. A big salute to you and a warm welcome to Dr. Gangadhar Sahu.
Thank you, Babita. My namaskar to all of you. Greetings from Bhubaneswar and blessings from Lord Jagannath. Also greetings from ISOPARB. Dear friends, friends of Gorakpur chapter, my dear members, leaders like Sadhana Madam, Amrita, Babita, and so on and so forth. So thank you very much for inviting me as the chief guest of this evening or as the president. So as the president, I have taken off. This is, I think, the second webinar I am attending. Gorakpur chapter is very close to my heart because of lovely friends of mine, and one of the best disciples of mine is there in Gorakpur. I want that physically I should attend one of such conferences in Gorakpur. Sadhana Madam, there are no words to express what a personality she is. So always my salutation to her. As regards today, as the president, I can say this much, that I have taken the oath, and my slogan for this year, let us walk the talk for ISOPARB. Very simple. So if everybody or every ISOPARBian, then if you do something for ISOPARB every day for 15 minutes, that is enough. We can take this ISOPARB to a greater height. So as regards the Yuva ISOPARB, the new concept conceived and delivered by Sadhana Madam. So it is a nice one. So now I am totally confused. Who is a Yuva? Am I old? I don't think so. I am also a Yuva because age is a number. And if you are younger by heart, then you are a Yuva. So I am also a Yuva, and therefore I am participating in this Yuva webinar of that is being organized by Gorakhpur chapter. Maybe I am an experienced Yuva. See, the objective of this webinar, Yuva webinar, or Yuva ISOPARB webinar is that let us involve all the younger mass, young people, young gynecologists, young pediatricians, and create awareness and motivate them to be ISOPARBians so that they can understand what perinatology is, what reproductive biology is, and they will be ambassadors of our society one day or other. Dear friends, to start with, Mangalam Bhagavan Vishnu, Mangalam Garudadhvaja, Mangalam Pundarikakhya, Mangalayo Tanohari. So thank you very much. You have invited me and my wholehearted support to ISOPARB and to Gorakhpur chapter. Long live ISOPARB, long live ISOPARB, long live ISOPARB. Thank you very much. Thank you.
Thank you so much, sir, for such lovely blessings and for such divine words. Now, I would take the opportunity to invite our special guest, Professor Usha Sharma. We all know ma'am is past president ISOPARB, and we have all witnessed a great tenure under her presidentship. So madam is National President ISOPARB 2020 to 22, Senior Consultant Obs and Gynae at SK Memorial Hospital and AK Memorial Nursing Home, Patna. She is Honorable Consultant Red Cross Polyclinic. Ma'am is advisor Safe Motherhood Committee FOX and presented many papers at FOXY, ISOPARB, RCOG and other society, contributed chapters in FOXY publications, and former East Zone Fellow Representative RCOG, Vice President, Secretary General, ISOPARB. A warm welcome to you, ma'am.
Can you hear me, Babita?
Yes,
Can you
ma'am.
hear-
Yes, ma'am.
Yes, ma'am.
We can hear you.
Okay. Now, first of all, thank you for such a nice introduction. I'm always taken aback when somebody says so many words. I think just my name, few lines should be enough. बाप रे बाप, मैंने 123 webinars किए हैं अपने tenure में only. So thank you so much for such elaborate and nice introduction. Now today's webinar is slightly different. It's known as Yuva ISOPARB, and the topic is really different and something which troubles all of us. Complexities of modern obstetrics. In the clinic, at least I always, every day, some nodule somewhere, there is some conduction defect, something in the fetus, and then I'm asked, what will be the prognosis of the baby? And I am really, really troubled to answer that question honestly. Sometimes I just say, I don't know. I will inquire and let you know later when you come for the next visit. Sometimes I send them for further tests. So that is going to be a really very, very good practical approach to our troubles. And Sadhana Gupta ji, Amrita ji, I see all known faces, as I said, seeing you people and talking to you people at the same time, enhancing my knowledge. Thank you for inviting me. I will always, always come to Gorakhpur when invited. Thank you.
Thank you so much, ma'am, for joining us and giving your pearls of wisdom. Now it is time to invite our guest of honor, Dr. Pragya Mishra Chaudhary. She is Secretary General ISOPARB, Consultant Infertility Specialist at New Life Test Tube Baby Center and NGM Hospital and Research Center, Patna. She is Secretary General ISOPARB, Chairperson of Genetic and Fetal Medicine Committee, Founder Secretary Bihar Chapter, Vice President Patna Obs and Gynae Society, even Secretary of the same society, Examiner for MRCOG Clinical Examination, recipient of several awards paid for excellence and leadership in IVF, Healthcare Professional of the Year 2018, George Mahoney Award, C.L. Javeri Award, J. Mishra Gold Medal, and MP John Gold Medal. Contributed chapters in 10 books and paper in national journals. She is Organizing Secretary of Conferences and Scientific Chairperson of ISOPARB Annual Conference 2016. A warm welcome to Dr. Pragya Mishra Chaudhary.
Thank you so much. Good evening to all of you, and thank you so much for the kind words that you have spoken about me. And at the outset, I would like to thank Gorakhpur ISOPARB chapter, I mean the Yuva ISOPARB chapter, along with Gorakhpur Obs and Gynae Society, and especially Dr. Sadhana Gupta, Dr. Amrita Jaipuria, Dr. Babita Shukla, and all those who have been involved in organizing this event today. And so chief guest, Dr. Gangadhar Sahu, and special guest, Dr. Usha Sharma. And so first of all, I really want to thank each one of you for showering this honor on me today. So I feel really privileged. And just today, Dr. Deepika Dekka called me and she said that, oh, suddenly, ISOPARB has become so active these days. So I said, yeah. So I said, I should thank, all the city chapters and presidents and secretaries and all my predecessors, especially Dr. Usha Sharma and Dr. Meena Samant, who are all, they have made ISOPARB so popular and they have made my job so easy, I must say. Coming to today's topic, I can see that, each of the topics have been so intelligently chosen, and it's a subject which is very close to my heart because I was the chairperson of Foxy Genetics and Fetal Medicine Committee. And, the whole idea, about having such topics is, we want to prevent birth defects. And let me tell you, ISOPARB, in fact, it's one of the oldest professional organizations, which, it's just sort of dedicated to perinatology. We have many organizations which are dedicated towards infertility, or, like ISAR, IFS, and we have a general organization like FOXY, but, ISOPARB is just dedicated towards perinatology. So, so it's really nice that, it's such an apt subject that you've chosen for today. And I wish this program all success. And I hope, that we have many more to come in the future, which I think all of you, your efforts are going to take ISOPARB to greater heights. So thank you once again for having invited me today as the guest of honor.
Finally, with immense pride and pleasure, I would like to invite the lady behind all these academies. We are talking about a person known for a hard work, sincerity, simplicity, leadership, and a profound knowledge. A lady with a charming smile and a hearty laugh. A great academician with 9 gold medals to her credit. She is the winner of Korean Award thrice for Best Scientific Forum, winner of
Okay, Babita, it's okay.
No, ma'am, wait here. So she is ICOG Governing Council member, National Corresponding Editor Jogi, and she has great academic excellence, 4 times Best Research Paper Award in AICOG, and thrice Dr. D.C. Datta Prize for Foxy Publication. Madam has organized several conferences, be it ISOPARB, the Suffolk Saving Mothers Conference, the Norjon Yuva Foxy, or UPCOG Conference. She is recipient of several awards, be it the Shailaja N. Pandit Women's Empowerment Award, Meru Hansotia Award, Dhuru Shah Award, R.N. Malhotra Award for Rural Services, and Economic Times Award. She is a dedicated research worker, an academician, orator, organizer, and trendsetter for 36 years in Foxy. A very warm welcome to you, ma'am.
Thank you, Babita, for a very generous introduction. And please stop share, Nisha. So once upon, I welcome as the capacity of President Gorakhpur chapter ISOPARB. I welcome all the faculties, all the dignitaries, Chief Guest Dr. Gangadhar Sahu, beloved past President Dr. Usha Sharma, Secretary General Dr. Pragya, and all the faculties who are with us, youngs and the mentors. With this program, actually, it was like creeping in my mind since a long time, and we have the interaction with Dr. Gangadhar Sahu. What has been what is the scenario today that the technology is getting too knowledge, too information in a small space of time, and the society is not ready, and the clinicians are not ready to what we should do in clinical practice. Second thing is that when we have got the high imaging, biochemical advances in the other field, actually it takes a time, at least 6 to 10 years, that we know that what is normal, what is the normal range, what is abnormal. And that has, we have to imbibe very slowly, we have to generate our own experience. And what is the important thing, that first we have to understand life before we do any intervention. So what is an important thing, I think all mentors and the teachers who are with us will be agreeing to it, that so many termination oriented obstetrics for a small thing, isolated marker, or sometime NIPT Moni is going to take, and suddenly everybody is talking of termination of life, which is so precious and in varied circumstances, because the patient may be having only this child and we are troubling it. So today we have selected this topic, and we have selected very carefully the Yuva one, because they are too technical, they are good in advances, and the mentors who will give their experience, their pearl of wisdom, that we have this knowledge, how to image, how to have this test, but what to do after that. what we have to do with the patient, with this mother, with this father, with this family, and with this fetus. So we are really very excited to look forward that what is going to have today in the discussion and what we will receive. And we welcome all the August audience as well who are with us. And we hope that we will have a very, very fruitful discussion. Thank you very much for being with us today. Thank you very much.
Thank you so much, ma'am. Now moving forward to a scientific session. Our first scientific session, the topic being NIPT, optimizing role in clinical practice. For this, I would like to invite our experts, Dr. Sukant Mishra. Dr. Sukant, next slide, please. And Gynae Society and founder president, Bengal chapter of Society of Vaginal Surgeons. Sir is member Penal and Ethical Committee of MCI West Bengal chapter and PhD Committee of West Bengal. He's peer reviewer, Journal of Obs and Gynae, and editor of Vivekanand Institute of Medical Science of Journals. He has publications in national and international journals and chapters in books, and is examiner of UG and PG courses. Our next chairperson, Dr. Mala Srivastav. Warm welcome to you, Dr. Sukant Mishra, sir.
Thank you.
Dr. Mala Srivastav is head of Obs and Gynae Unit, Gynae Oncology Unit, and senior consultant and professor GRIP MER, and Gynae Endoscopic and Robotic Surgeon, Sir Gangaram Hospital, New Delhi. Madam is Vice President-elect ISOPARB 2324 and past President AOGD 2021. She is a recipient of several awards, that is APJ Abdul Kalam Award and Subhash Mukhopadhyay Women's Health Icon Award and Women Medical Professional Award and Circle of Excellence Award. Ma'am has held very important positions, be it in FOXI, ISOPARB, or AOGD Society, where she has been Journal Chairperson. She is member of Governing Council of ISCCP, Secretary ISOPARB Delhi Chapter, Chairperson ISOPARB Quiz Committee, and Chairperson of Community Health Committee ISOPARB. Ma'am is member of several societies and executive member IMS Delhi Branch and Joint Secretary NARCHI Delhi Branch. A warm welcome to you, ma'am. And our next chairperson is our very own Dr. Amrita Sarkari Jaipuriyar. She is consultant of Jaipuriyar Hospital and Research Center and is also affiliated to Garg Hospital and Ahmed Hospital. At present, she is president of Gorakpur Obs and Gynae Society and secretary of Menopause Society and ISOPARB Society, Gorakhpur chapter. Warm welcome to you, Amrita ji.
Thank you.
And a speaker for today is Dr.
Moni.
Dr. Moni Bhatia. She is ex-consultant, Sir Gangaram Hospital, New Delhi. And presently, she is Chief Clinical Geneticist and Fetal Medicine Specialist, Noble Hospital, Rohtak, Chairperson of Fetal Medicine Committee, Haryana Obs and Gynae Society, Executive Member, Stillbirth Society of India. She has numerous publications in national and international journals and has reviewed articles in international journals. And she has a special area of interest being recurrent miscarriage, fetal medicine, dysmorphology, and skeletal dysplasia. A warm welcome to you, Dr. Moni Bhatia. Now, I hand over the session to our chairpersons to conduct this talk.
Thank you so much, ma'am, for this nice introduction. I would like to thank ISOPARB Gorakhpur chapter for giving me an opportunity to speak in front of you all. It is an honor for me to be a part of this educational webinar, and a special thanks to Dr. Sadhana Gupta ma'am for giving me this opportunity. I met her for the first time in Varanasi, and she is really a gem of a person, and we get positive vibes from her all the time. And she's very encouraging for the younger generation. Thank you so much, ma'am. So, is the slide visible?
Yes, we can see it.
Yes,
Yeah.
yes.
So I'll be talking on NIPT optimizing its role in clinical practice. NIPT is the most recent advancement in the field of aneuploidy. So before going into the details of NIPT, we'll start with the talk on what is aneuploidy. Aneuploidy is the presence of abnormal number of chromosomes. As you can see on the left hand side is a euploid chromosomal complement where there are 23 pairs of chromosome. And on the right hand side, you can see trisomy 21, that is extra chromosome 21, which is present. This is the case of Down syndrome. And why do we keep on discussing about Down syndrome? Because it is one of the most common chromosomal cause of mental retardation, and screening is available for Down syndrome. It has a prevalence of 1 in 800 live births. Trisomy 18 and 13, though, are less common, but also can result in a live born baby, and the testing for these are also available. So coming to the aneuploidy screening, it all started in 1970s when only maternal age was the criteria for detection of Down syndrome, and it had a detection rate of only 30%. And then came era of alpha fetoprotein, followed by triple marker screening, quadruple marker screening. And then in 2000 came combined screening in which double marker plus NT was incorporated, which increased the detection rate to 82 to 87%. And in 2011, NIPT was introduced, which is cell-free fetal DNA testing. It was introduced into clinical practice, but it came in India in December 2012. And thereafter, it has spread like wildfire because many companies are coming and promoting it every other day because of the large number of deliveries taking place in India every year. And it has the highest detection rate of 99%. But it is not that we can offer NIPT to all the cases, so we'll be discussing them one by one. So basically, what exactly is NIPT? It is a cell-free fetal DNA which is present in the maternal plasma. In the maternal plasma, most of the DNA is from the mother. It is around 90% from the mother and part of it is from the fetus. The fetal fraction increases gradually with the increasing gestational age. It has been found that it can be detected as early as 7 to 9 weeks of gestation. Some articles also states that it can be detected as early as 4 weeks of gestation, but the amount of the fetal fraction is very less and we cannot proceed with any testing on that fetal DNA. So it should be done at more than 12 weeks of gestation. Apart from that, it disappears within hours of delivery. It is also very important because as it disappears within hours of delivery, the previous pregnancy does not have any effect on the current pregnancy. Also, this fetal DNA, but it does not truly represent the fetal genotype. It represents the placenta because the cells, whatever fetal DNA we are getting from the maternal blood, it is the placental trophoblastic cells. So it can come out to be positive in cases of confined placental mosaicism. It does not truly represent the fetal genotype. There are various techniques which are used: the whole genome massively parallel sequencing, chromosome specific massively parallel sequencing, and the SNP based approach. Whenever we are offering NIPT, we need to ask the vendor what methodology they are using, because SNP based approach can detect triploidy, while the MPSS, the counting based methodology, is not a good test for triploidy. So as far as these techniques are concerned, whole genome and chromosome selective MPS, in these technique, we do massively parallel sequencing. We do not separate the maternal and the fetal DNA. We directly sequence all the chromosomes, and then these sequences are mapped to the DNA and the targeted chromosome of origin we know. And based on that, we can try to identify whether a part of the chromosome is missing or an extra chromosome is present. It has an advantage that it has a higher depth of sequencing and we can get the results even at a lesser fetal fraction. As far as the SNP based approach is concerned, in this various polymorphic markers are selected, and based on that we are able to differentiate between the maternal and the fetal genotype, and we can know whether extra or missing chromosome is present or not. SNP based method is better because in this we can identify the uniparental isodisomy, consanguinity, non-paternity. Apart from that, it is a good test for triploidy, but it is not a good test in cases of IVF with the egg donation or in the patient who had received any organ transplant. As far as the sensitivity and specificity goes, it has the highest detection rate. The sensitivity is very high. It is 99.2% for trisomy 21. As compared from trisomy 21, for trisomy 18 and 13, it is comparatively less according to the ACMG 2017, but ACOG 2020 says that for trisomy 13 and 18, the detection rate is 98 to 99%. So it is a very good test because with a high sensitivity and a very less false positive rate. But it is not like a simple blood test where you can order hemoglobin, CBC, LFT, KFT. There are various prerequisites whenever we are ordering NIPT, and pre-test counseling is very, very important. Prior to offering this NIPT, a baseline ultrasound is required where we look for the gestational age. The dating scan is very important. Apart from that, the number of fetuses, whether any vanishing twin is present or not, or any structural malformation is present or not. Because if for that matter, if there is increased NT, or if any structural malformation is present, or if vanishing twin is there, then we say that this is not a good test. In pre-test counseling, the important point is we have to tell the family that this test provides information regarding chromosome 21, 13, 18 and sex chromosome. It is not a good test to look for all the chromosomes. Though commercially available in the market, the whole genome CNV analysis, the rare autosomal trisomies, for the microdeletions also it is available. But the guideline says that it should be offered only for the common trisomies. And if you want to rule out other microdeletions, then direct invasive testing needs to be offered. Another important point is it is not a diagnostic test, but a high efficiency screening test. If it comes out to be positive, invasive testing is required. Here I would like to share one of our cases. Once the NIPT was offered, the patient was not willing for amniocentesis. NIPT was offered, and in the NIPT, we did not get any result. There was low fetal fraction. Then the patient came after 2 weeks, the sample was repeated, and again it took another 2 weeks. And when the result came, it came out to be positive for trisomy 18. Now the patient had already reached 20 weeks and she did not had any time, and she did not want to undergo amniocentesis, and then went away straight away with termination of pregnancy. When the fetus was brought to us for evaluation, there was no abnormality identified in the fetus, and the workup of the fetus turned out to be normal. The karyotype of that fetus was normal. So it is very important that it is not a diagnostic test. It should always be confirmed by invasive testing. Another important point is we should always offer the family, review the family history. It should be offered if there is no family history of any genetic disease, no history of any recurrent abortions. There was a family in which the previous child had developmental delay. The microarray was done somewhere else and it was normal. So then the family was lost to follow up, and then in the next pregnancy, they went to their treating doctor and showed all the records that they had a previous child with developmental delay and all the reports were normal. So the doctor ordered NIPT, saying that if that is normal, you can continue ahead with the pregnancy and everything is going to be fine. They continued the pregnancy, and the second child also had developmental delay. So it is very important. NIPT is not a Ramban that will give you answer for all the disorders. Apart from that, if there is a previous history of recurrent abortions, it is not a good test. We had one another case where there was a history of 3 abortions, and in the 4th pregnancy, double marker came out to be positive. NIPT was offered and it was normal. They continued the pregnancy, and after 2 years, they brought the baby to us for evaluation because of developmental delay. And it was found that there was deletion of chromosome 7 and duplication of chromosome 14. And when the testing on the parents was done, mother was a translocation carrier. So NIPT would not detect all the chromosomal abnormality. This should also be clear to all. And the another important point is negative test result does not ensure an unaffected fetus. If it comes out to be normal, it only rules common chromosomal aneuploidy, but it cannot guarantee an unaffected fetus. Because there was a case in which the NIPT was normal. In that case, the fetus developed CCAM, that is congenital pulmonary airway malformation, at 23 weeks. And in another case, the fetus developed short long bones at 30 weeks, and later it was found that the fetus had achondroplasia. So it is very important. But when we give so many information to the family, the patient is confused and asks us, what would you have done if you were at our place? We'll tell them that we cannot be in your place. It should always be a non-directive counseling. We should tell all the facts to the family, let the patient decide. We can tell them that yes, most of the patients do such things, but we cannot be in your place. The patient has to decide on its own. Also, in the pre-test counseling, we should tell them that there are chances that we may not get any result and the resampling may be required. It is possible in 3% of the cases. In those cases, the chances of aneuploidy are higher as compared from the other cases. No call rate can be because of the low fetal fraction or inappropriate blood collection or assay failure. But it is also known when the resampling is done, we get results in 60% of the cases. There are a number of causes of low fetal fraction. It can be because of aneuploidy like trisomy 18, 13, triploidy, because the placenta is small and less fetal fraction is there. Apart from that, obesity, immunological disorder in the mother, or if the patient is on heparin, then also there are chances of low fetal fraction. In those cases, if the patient is on heparin, the NIPT sample should be taken as far as away from the last dose of heparin. So if we do not do proper pre-test counseling, the patient comes to us for result after 2 weeks and we say now resampling is required, the patient gets very furious. So it is very important to tell the family. But what takes if we do not get any results? ACOG says because of the increased risk of aneuploidy, direct diagnostic testing can be offered. Or if the patient has time, it is only 16 weeks, then repeat cell-free fetal DNA testing can also be offered. Society of Maternal Fetal Medicine says that comprehensive ultrasound evaluation and diagnostic testing should be offered. Coming to NIPT in twins, SNP based methodology, as we have already discussed, is better. The sensitivity for trisomy 21 is 99%, and it can identify the vanishing twin and chorionicity because different polymorphic markers are used. But if it comes out to be positive, amniocentesis of both the fetuses are required. Coming to the sex chromosomal abnormality, sensitivity is lowest for the sex chromosomal abnormality. It is 90%, but the positive predictive value is very less. It is 14% for Turner syndrome, 50% for Klinefelter, and 70% for XYY. It is also known that in 8% of the cases, if you are getting abnormal sex chromosomal abnormality in the NIPT, it is because of the abnormal maternal karyotype. It can be because of the mosaic Turner of 47XXX. So here I would like to discuss this very interesting case. This is a case of a 33-year-old lady. She was a fourth gravida. She had a 7-year-old boy. This boy had Down syndrome and had expired on day 17 of life and had trisomy 21. With this history, with the previous child with Down syndrome, there is a 1% risk of recurrence in the next pregnancy. So either direct invasive testing or NIPT can be offered with a proper pre-test counseling. But anyhow, in this case, the treating doctor got the double marker test done and it was normal. So, but the family was very anxious and wanted to know 100% answer that what is going to be the future of this baby, because they already had one baby who had expired. So the doctor then ordered NIPT in this case. In this case, when the NIPT was offered, it was positive for Turner syndrome. Chromosome 21 was low risk, but it was positive for Turner syndrome. And we know that the positive predictive for Turner is only 14%. Then we offered them amniocentesis because that is a gold standard and a confirmatory test. When the amniocentesis was offered, it was normal. The QFPCR and the karyotype report was normal. Here also it is very important because the patient was very furious that why the double marker was done, why the NIPT was done. We would have gone straight away with the amniocentesis because that is the gold standard test. If the NIPT is being offered, we need to tell the family what are the pros and cons, what are the chances of false positive rates with a different methodology, what is the chance of no call rate. These all the things should be discussed with the family prior to offering NIPT. The number of causes of false positive results in NIPT, as we have already discussed, that the fragmented DNA which is present in the maternal plasma is from the mother as well as from the placenta. So it can be positive because of the placental causes like confined placental mosaicism or because of vanishing twins, or it can be because of the maternal causes like any maternal aneuploidy XXX or mosaicism or copy number variations. If any abnormality is present in the mother, then also it can come out to be positive. Or if the patient is having any malignancy or fibroid, then we can get any complex or bizarre results. Multiple deletions and duplications can be there. So in those cases, it is not a good test. It is found that if the patient is having any malignancy, it may be fibroid, then you get bizarre results in 80% of the cases. So various advances in NIPT. Now the labs are commercially offering all these tests like the whole genome non-invasive prenatal testing for microdeletion, for rare autosomal trisomies, and for single gene disorder. For microdeletions and for the rare autosomal trisomies, the whole genome NIPT is available in our country, though not available for the single gene disorders. They say that it is validated. The commercial company says that it is validated and can be offered, but the ACOG, ACMG, and the other professional bodies, none of the professional bodies recommend this test for the detection of the whole genome or microdeletions, because it is known that it has a low positive predictive value and a high false positive rate. For that matter, if there is any heart abnormality in the fetus and you want to rule out 22q microdeletion syndrome, the DiGeorge syndrome, then it is better to go straight away with amniocentesis and get the testing and the microarray analysis done. As far as the NIPT for single gene disorders is concerned, it is available in UK for the autosomal dominant disorders, and that too only for the paternally inherited mutations like achondroplasia, tuberous sclerosis. It cannot be offered for the maternal mutation because it is very difficult to interpret, because most of the DNA which is present in the mother is the maternal DNA, only partly the fetal DNA is present. Now the companies are offering for the autosomal recessive disorders like beta thalassemia as well, where they are looking for the paternal mutation, not for the maternal mutation. If that paternal mutation is present, then they go ahead with amniocentesis, but we are not offering it. And even if it is available in India, it will not be validated. It may take few years before it is validated and it is commercially available. Another important question is, can NIPT replace invasive testing or the serum screening? It is always the patient's choice. Pre-test counseling is important. If the patient wants to rule out only Down syndrome, that yes, that it can be offered. But if we consider that all chromosomal abnormalities are concerned, the chance of all chromosomal abnormality increases. As we can see in this table, that at the age of 40 years, the chance of all chromosomal abnormality is 1 in 40, which is very high. If you're offering invasive testing for a risk of 1 in 250, then even at the age of 20 years, the chance of all chromosomal abnormality is 1 in 122. So these things should be discussed with the family, that this is the chance, this is the percentage of cases of the chromosomal abnormalities which will be detected by the NIPT and the invasive testing. These are the ACMG recommendations. It says that NIPS should be performed at 12 weeks of gestation or later to reduce no cause due to low fetal fraction. NIPS cannot be used to detect all chromosomal abnormalities. It does not detect congenital malformations for which good level 2 scan is required. It cannot predict abnormal pregnancy outcome for which screening is required, like low PAPA can predict IUGR preeclampsia, increased AFP can predict neural tube defect, likewise unconjugated estriol, if low, can predict steroid sulfatase deficiency. So it cannot replace the serum screening. And it is not a good test for rare autosomal trisomies, microdeletion, whole genome CNVs, as well as for single gene disorders. So I have only few take-home messages. Pre-test counseling is very important. Counseling before ordering any test. The NIPT does not exclude all genetic disorders, and confirmatory testing is always required. NIPT for single gene disorder, expanded NIPT, and rare autosomal trisomy should not be offered as of now. Thank you so much.
Thanks, Dr. Moni. That was really a very exhaustive, informative, scientific deliberation from your side. Definitely, NIPS or NIPT is a revolutionary technology. It is the hottest molecular test ever in the history of medicine. NIPT has changed the screening during pregnancy, and definitely it has a both diagnostic test. We have to pre-test counseling is very important. We have to tell that it's a screening test, not a diagnostic test. That has to be made very clear to the patient. And of course, it has its own advantages with very high sensitivity and specificity. In our practice, basically, if a girl is more than 35 years old, we do offer them NIPT as a straightaway test, as a screening test, instead of the dual marker. Of course, NT-NB scan will be there, but instead of dual marker, we can offer them NIPT as a first test in girls who are 35 plus in age. And that can save us time and also the problem of first doing the dual test, which comes positive, and then doing NIPT as a screening test. And we have to tell them that amniocentesis is the diagnostic test. So we have to counsel each and every patient separately, give them importance, make them understand that this is nothing but a screening test, though with high sensitivity and specificity. Definitely, in cases of doubt, diagnostic test like amniocentesis or CBS has to be done to rule out chromosomal abnormalities. Thanks, Dr. Moni. That was a real good treat to us, all of us, and brush up with a very nice scientific points that you have told to us.
Thank you so much, ma'am. Thank you, ma'am.
Is it okay, with permission of the chair, to ask a question out of curiosity? Is it okay?
Yes, ma'am. Go ahead.
Yeah. No, it was a very good presentation. And since you are an expert, I would just like to ask you, suppose there's a patient who on NT scan, you find that the nasal bone is absent, but the combined testing, it has come as a very low risk, it's about 1 in 1,000 or something like that. So would you offer her NIPT, or would you go for an invasive testing? Or would you wait till the level 2 scan, look for other in case if some more soft markers come up and then you make a decision?
As far as nasal bone in the first trimester is concerned, it always needs to be followed up with a level 2 scan, because nasal bone in the first trimester, even if present or absent, doesn't make a difference. If it is hypoplastic or absent in the second trimester, then it needs to be amniocentesis is indicated. As far as the NIPT goes, the maximum percentage of hypoplastic nasal bone cases is because of trisomy 21. Rare cases can be because of the rare deletions, duplications as well, but most of the cases are because of trisomy 21, which will be picked up by NIPT. This information needs to be given to the family that yes, NIPT can be offered, and if in the level 2 scan there is no hypoplastic nasal bone and it is normal, then they can continue ahead with the pregnancy. But as a protocol, if hypoplastic nasal bone is present in the second trimester and the NIPT is normal, we do not go ahead with the invasive testing. We tell the family that most probably the baby is going to be fine, and then continue ahead with the pregnancy, because in very less percentage of the cases, it is because of some other chromosomal abnormality apart from Down syndrome.
So now why I asked the
We
question?
will, I just, Dr. Sukanto is going to say, because, yes, Pragya, we will take the question because Dr. Sukanto has one commitment, so we will like.
Only, just 2-3 days ago on the weekend, for RCOG conference, I was asked the same question. Absent nasal bone, combined testing, low risk, would you go for NIPT or would you go for, what would you do? So in fact, I said that, I would go for NIPT because it would increase the sensitivity. But the thing is that, guidelines say that don't go, because NIPT is also a screening test. So don't go for 2 screening tests. That's why so I was just trying to clarify, the question, the answer to the question which I was asked, not testing your knowledge as such. So
No, just Dr. Sukanto, we will take questions. Dr. Sukanto has to leave. Your question is very valid. That is everybody's question, Pratya. We all have these issues. So Dr. Sukanto, and then we will continue with discussion.
Thank you, Dr. Sadhana. At the outset, I would like to thank Dr. Sadhana, Dr. Amrita, Dr. Kavita, the entire Gorakpur team for organizing this beautiful conference. I don't know, I cannot open my video. You can't see me. Is the admin can do something for that, Dr. Nisha or somebody? As a matter of fact, I'm having some problem with the wave as well. Am I audible?
Yes, sir.
Yeah,
Yes,
fine.
sir. Yes, sir.
Oh, it's fine. So thank you, and I must express my sincere thanks to Dr. Gangadhar Sahu, Shadi, and Dr. Pragya as well, and her questions also. First thing first is that Dr. Mani has nicely explained what is the aneuploidy. Now, we know the magnitude of problem the aneuploidy can create in an individual life, in the family, and for the society as a whole. So the bottom line is it needs to be screened. And the second important thing is that counseling is extremely important. 2 things are important while undergoing these things. One is counseling, that is pre-test counseling and post-test counseling. And second is interpretation of the test. Now, in the pre-test counseling, it is extremely important that the definition of screening and diagnosis, because there are many screening tests available, but the patients are not aware of it. What I feel that there is a part that the patients should know, because we know it, but the patients they don't know. So the screening means that we are trying to identify the high risk places, and there are diagnostic parts that we need to do to confirm what we have found as a high risk patients. And in this information should be shared to all women, because one has to know, because of various reasons, the patient might decline not to go for screen test. So they should have that right to decide what they are going to do. Once they decide that yes, we'll be going for the screen test based on their personal risk factor for a particular anomaly, then the availability of the test, its cost, how long it will take for the information to be available, that should be informed. And as Dr. Pragya was saying, that 2 screening tests should not be done in a particular patient. Like NIPT, definitely the screening test, it can be done as a follow-up of those particular patients he's talking about, but then there is always 2% residual risk. So the thing is that statistical interpretation of the test result is extremely important. Whenever the report comes, that needs to be communicated with the patient. The doctor must know that if I say that the screen test is positive, that means there's a high chance the result will be positive. But that doesn't mean that the individual is having that particular problem. Similarly, when the
We lost
Internet
connection.
disconnected, yeah. So Amrita ji, you can give your inputs by that time.
Okay. At the outset, I would like to thank Sadhana ma'am for making me a part of this wonderful, informative webinar. And my respects to our chief guest, Yuva Dr. Gangadhar Sahu sir. And my regards to Dr. Usha Sharma ma'am. And respects to our guest, Dr. Pragya Mishra ma'am. And all the dignitaries on the dais, Reena ma'am, and chairpersons who have joined me, Dr. Sukanto and Dr. Mala Srivastava. Dr. Moni, indeed, it was a wonderful talk, and there's been a long association between aneuploidy and maternal age. But now with the advancing tests and everything, we see that the number of viable aneuploids are delivered through younger ladies. Now the younger ladies who are considered to be at low risk, they are delivering more of the aneuploid babies. So aneuploidy, so NIPT, should it be offered to all the women or not, is still a question mark. Furthermore, listening to you and like even we are offering NIPT to other patients, to a few patients. What I have understood that NIPT for now is simply a consolation kind of a thing, or it gives some time for to buy. The patient gets counseled more and more, waiting whether the baby is abnormal or not, and automatically the mindset of the patient develops that she might need to undergo an invasive test, or she might need a termination of pregnancy. Because as you also rightly said, that if NIPT is positive as a screening test, we need to do this thing, invasive test. And if NIPT is negative also, then it is not necessarily going to be that we are going to have a healthy baby. So definitely we need to work more on this, think more about this test, whether we should offer it or not. Even that is a question mark for me. Like I'll leave it to Gangadhar Sahu sir and Usha Sharma ma'am, Reena ma'am and Sadhana ma'am to give their expert opinion, because NIPT is not conclusive at all. It like leads us nowhere. We definitely need another test for that, or we need to wait. So over to the experts.
Amrita ji, I have one thing to say.
Yes,
only one line. That if they have a family history of aneuploidy, in that case, in younger women also, they should be offered NIPT. Otherwise, women more than 35 years of age, provided they can afford it, because in our part, affordability is also a problem. We offer them, we tell them about the test cost, and they back out. They say, ultrasound wala hi test karwa dijiye. In spite of us trying to convince them that quadruple test is there, but still you cannot say, it's quite late. 18 weeks nowadays we are doing quadruple test instead of 20. But 12 weeks and 18 weeks, this is a big gap. But you can't explain this to the patient. But it should be offered when there is a family history to younger ones, and over 35 if they are the older age group.
Ma'am, my question is, in any case, we have to confirm it through the invasive test.
Oh, yes.
So, I mean, that was my concern.
Will answer it. I think you have already answered a little bit. Please, you are the best person to give this.
Reena ma'am wanted to say something.
I would like to add on this.
Reena ma'am,
please unmute yourself.
Reena ma'am, you're mute.
I want to say that you cannot subject every suspected patient to amniocentesis. That is an invasive test.
Yes,
And
ma'am.
what in the form of screening, you are just selecting a population which is having a high chance of the aneuploidy or chromosomal anomalies. Those subject, if they come out to be positive, then we are going to do amniocentesis. And how many NIPT negatives are coming out to be positive, this you have to see. That is why the counseling part is very important, that you have to explain to the patient कि आपको ये 100% result नहीं देगा और हम आपको straight forward injection लगा के पानी भी नहीं निकाल सकते हैं, because it is going to be invasive. So this part has to be understood by the patient, and every patient cannot be subjected directly to amniocentesis. That is why the screening part is to select the population.
Just a minute. Screening we are already doing through the soft markers and the quadruple test and the dual marker test. So why NIPT in between?
You can choose.
That is my only question.
Because the sensitivity and specificity of NIPT is more than the dual one. So you can go directly to NIPT where you are suspecting, where the group of population is at a high risk, and the group who is not at a high risk, if they have an abnormal baby in the future, they'll come to you. मैंने आपसे तो दिखाया था और बच्चा तो abnormal निकला. So those patients who can afford, you should go for a dual test. वो आप पूछिए हर patient से, अगर वो कराना चाहता है तो जरूर कराइए, because the next time when she comes with an abnormal baby, the whole brunt will be on your head.
And I personally feel with the advanced maternal age, amniocentesis is better because apart from Down syndrome, the chances of other chromosomal abnormalities also increases. If it is a young age and double marker is positive and the patient is not willing for any invasive testing, in those cases, NIPT can be offered, and also in case of IVF pregnancy where the patient is not willing to take a minimal risk of abortion. But I personally feel with the advanced maternal age, it is better to go ahead with amniocentesis, because if we rule out Down syndrome and later the baby is affected with some other chromosomal abnormality, then also the whole blunt is on us, that why didn't you ask her to go ahead with amniocentesis?
No, but then after NIPT, you will offer them if at all it comes to be positive or negative. Post-test counseling is also important.
Very important,
Negative आएगा तो भी हम बताएंगे कि see, we are not 100% sure that you are not going to have abnormal baby, and positive आएगा तो definitely we have to counsel for amniocentesis. Let the patient choose. You are not giving 100% result with any of the screening tests, be it clinical, be it dual, be it quadruple. So all that depends upon the counseling of the patient. Let her accept what she wants.
Actually, मोनी जो मैं देखती हूँ, what is the Western versus, क्योंकि ना हम लोग, why I have kept this thing, that this is a very gray area, what Pragya says and everybody's question. First of all, for any screening, we should do universal screening. What is the recommendation that we should offer the screening? It is हमेशा इंडिया में लोग बोलते हैं कि बच्चा ठीक रहेगा, but we have to say that it is only for the few aneuploidy. That is only few. It is not covering sex chromosome. It is not covering the rare one. Secondly, what I say in the like now all Western world that they offer, if the couple says we are not at all interested in any genetic aneuploidy and we are not bothered, we are going to have pregnancy, it's okay. Though they say that the reasons for not having screening should be documented. So it is for our safety. So actually the issue is we are taking too much on ourselves. So the patient decision, like it is a IVF baby, it is at 45 years. Any case, if ultrasound is fine, double screen is fine, they want to continue, then it's okay. In my clinical practice, what Amrita was saying, hum log kya karte, what is my, so if the double marker screening say it is 1:150, it has crossed it says screen positive, but it is 1:157, 170. And the patient is totally annoyed कि हमको कहाँ भेज रहे हैं amniocentesis के लिए, and we don't know. Then we can say that you do NIPT if it is negative, that, and the ultrasound is also positive. Like we have to say that the second trimester ultrasound is also very, very good. It is perfect. Then you can be rest assured. Then we can offer, yes, do NIPT. If it is negative, then you can be pretty sure that it is quite okay with the good ultrasound. But if it is positive, then you have to. So I give for 27 million, we cannot offer NIPT. No way in next 10 years. And I think every world will also return to it. But here it is thing, people don't want, what Reena ji says, people also don't want invasive tests. It has got its own issues of abortion, and sometimes it may be the only child in their life. And we have to be like concerned for it. So NIPT is midway between, I do for if screen test is positive, it is, and the ultrasound is totally good. Then I said, do NIPT. If it is negative, then it is. So ultrasound, we cannot forget a fantastic ultrasound, which is totally perfect. And we really, I'm very sad about it that the people are coming for what you say, termination of normal baby because of the screen positive. And screen positive, I am really concerned about screen positive writing. It should be just 1:150, 1:250, and let the clinician and the patient should tell. Screen positive make the things very, very panicky. स्क्रीन पॉजिटिव का मतलब क्या, अगर आदमी 150 बार प्रेग्नेंट होगा तो उसमें से एक बच्चे को डाउन हो सकता है या क्रोमोसोमल एब्नॉर्मलिटी. सो साइंस हैज बिकम वेरी इल्यूसिव, very dicey, and we have to introspect that I am very much like reluctant to see this screen positive word. It is 1:150, that is. It is 1:1, 1:70, that's it. Let the clinician decide. So gray areas, that's why there are so many questions from Amrita, from Pragya, very, very genuine questions. And Moni have done wonderful job. Congratulations.
Nagna ji, one question, Sadhana, one question. On screen positive, how can you offer abortion?
No,
Ma'am, people are offering. We should not offer. Amniocentesis versus
NIPT. Amniocentesis versus NIPT.
I have seen few patients coming that previously it was positive and the doctor terminated the pregnancy only on the basis of screen positive without getting any.
No,
NIPT.
you cannot do that.
That is something very, very wrong.
Yes.
Madam, I would like to add, madam. I would like to add, Dr. Pragya's question.
Was there or not?
Yes, ma'am. Ma'am, Dr. Pragya's question was very vital, because if it was some other marker, we could have let it go. But absent nasal bone has a likelihood ratio of 1:9. So we have to follow it with an amniocentesis. We have to follow it with an invasive test. Only then we can rule out Down syndrome. And Madam Reena was very correct in saying that instead of double marker, rates of NIPT are coming down. So we can universally offer NIPT, but not NIPT in a case of absent nasal bone. That is a bigger problem, as this is what we have done.
But ma'am, double marker should also be offered in those cases, because if there is low PAPE, then you can do the screening for preeclampsia, start the patient on ecosprin. Both have their own roles. NIPT cannot replace the serum screening. Serum screening should be offered in all the cases, irrespective of offering NIPT or not. And any test should be offered. It should not be ordered.
Yes.
Yes. That is to be offered and that is to be counseled. जब हम लोग इतना लड़ रहे हैं, तो पेशेंट को क्या समझाना कितना मुश्किल है, you can understand.
So Amrita, Babita, I think
so we had a very fruitful discussion today, and yet the gray area remains. Again, we will be always wondering whether to offer NIPT or not, but then still discussion should always continue.
नहीं, Babita ji, there is a World Congress में मैंने chair किया है this NIPT पर 2 years ago, and the general, one Australian speaker, one speaker from UK, and they all said that it should be offered in high-risk cases.
Yes.
It's up to the patient to accept it or not.
Yes, it has to be.
Ma'am, why I understand is we should offer double markers, because that is the initial screening test, plus it screens out many other conditions also, like your IUGR and PT and all that. And if there is any structural abnormality or the NT is raised in the 11 to 14 week scan, then no role of NIPT, goes straight away for invasive testing.
Yes,
but
that
if there
is
is
what
no
I was
structural
trying to say.
abnormality, we can offer NIPT if the patient is like a bit apprehensive about invasive testing. But then
NIPT is not for structural anomaly anyway.
remains.
NIPT is for aneuploidy.
No, ma'am.
NIPT is
She
not
means
for
to say.
structural anomaly.
No, I mean the NT
Like
is
the
raised when you
association.
find any other marker in the ultrasound, any soft marker. So that becomes a high risk patient, you go for invasive testing. Like what I gathered from
High risk because of there are so many factors to make it a high
so
risk.
many soft markers are there. Suppose she has other soft markers.
So the previous is after the second class.
Previous obstetrical history or age.
Yeah. After the second talk.
Yes,
This
yes.
will again come.
So I hand over this virtual dice to Dr. Aruna Chaparia, Secretary of Gorakhpur Obs and Gynae Society, to conduct further sessions. And thank you, everyone. Thank you, Sadhana ma'am, for giving me this opportunity.
Thank you, Dr. Babita. The first session had a really very good discussion. And with the blessings of our dignitaries and seniors, we move on to our second session to discuss isolated ultrasound soft markers and its implication. It is my privilege and honor to introduce experts for this session. May I have the CV?
मेरा हो गया अरुणा विजय एंड अलका को इंट्रोड्यूस करो
बोलूंगी आपके बारे में ना आपके बारे में I always love to introduce Dr. Sadhana Gupta ma'am, who have a long list of credentials, 9 gold medals during medical career, recipient of many social awards, and she has served FOXY at national and international forum. Welcome Sadhana ma'am. बस इतना थोड़ा सा ही आपके लिए.
Thank you. Thank you.
Next, please. Dr. Vijay Lakshmi. Ma'am has enormous amount of dedication towards academics and many publications goes to her credit. She is senior consultant, OBGY, Sundaram Medical Foundation, Chennai, past president, OGSSI, past executive committee member, TNFOG, member practical obstetrics committee, FOXY. Ma'am has won Best Paper Award in AICOG 2014 Patna, Treasurer AICOG 2015. Her special area of interest are high-risk obstetrics and midlife health. Ma'am has contributed many chapters and she has written books on hirsutism in FOXY's Handbook in Endocrinology, and ma'am has been awarded Asia GCC Women Health Career Leader Award. A warm welcome to you, ma'am. Next, please. Dr. Alka Kutti, a medico-legal expert, consultant, obstetrician, LLM, and human rights National Coordinator, FOXY Ethics and Medico-Legal Committee, past President, Indian Medico-Legal and Ethics Association, founder, member and National Secretary, Human Milk Banking Association of India, editor of textbook on medico-legal issues, winner of Dr. N.B. Kumtha Award in IYCN, participated in relay song based on life of Tatya Lahane that made entry in Guinness Book of World Record. Welcome you, ma'am.
Thank you.
And our speaker for today's session is Dr. Dipti. Please display the CV. Ma'am is Associate Professor, Department of Medical Genetics, SSPGI, Lucknow. Her area of interest are dysmorphology, skeletal dysplasia, prenatal diagnosis of fetal malformations, reproductive genetics. Many publications goes to her credit and they have been published in national and international journals. Her recent research projects are on craniovertebral junction anomalies, fetal malformations, and dysmorphology. Welcome, Dr. Dipti, for your deliberation.
Thank you, ma'am. Screen visible, no?
No, ma'am.
Visible, Dipti?
No. Screen is not visible, ma'am.
Okay, ma'am. I'm trying to reshare.
Open करके रखो presentation.
It is still in the sharing mode now. You have to once stop the sharing and then share again.
Okay, ma'am.
You open your presentation first, Deepti. Then
it is
start sharing. Yeah. Because your presentation has to be opened up before you start screen sharing.
Is it visible now, ma'am?
Yes.
Yes. Yes.
It is visible, ma'am. You do it full screen and you can start.
Okay. So first of all, I would like to thanks the Gorakhpur chapter of the ISOPARB Society for this invitation, and special thanks to Dr. Sadhana Gupta Madam for the invitation. And today I'll be talking about isolated ultrasound soft markers and their implications. Thank you once again. So chromosomal abnormalities occur in around 1.1 to 0.2% of live births, and most commonly clinically significant aneuploidy is Down syndrome. So the incidence of Down syndrome is around 1 in 800 live births. It is a leading cause of mental retardation. Sonographic findings in Down syndrome babies include both structural abnormalities as well as non-structural abnormalities. These are also known as markers or soft markers. Other chromosomal abnormalities that can be diagnosed in ultrasound include trisomy 13, 18, monosomy X, and triploidy. So the soft markers were introduced to improve the detection of trisomy 21 over that achieved by age-based screening and serum screening. So serum screening test strategies have greatly evolved in the last 2 decades. And now with the advent of non-invasive prenatal screening, that is NIPT, so the whole scenario has changed and the importance of soft markers have also shifted. So coming to soft markers, they are non-specific markers. They are often transient and they are readily detected during the 2nd trimester ultrasound. They are not pathological themselves. So these markers are used to screen for or to adjust the risk for Down syndrome and other aneuploidies. These markers are always seen in normal, may also be seen in normal fetuses, but the incidence is increased in infants with chromosomal abnormalities. So what is isolated soft marker? So soft marker is isolated when it is identified in the absence of any other structural abnormality, when there is no growth restriction, or when there is no additional soft marker following a detailed ultrasound examination. So whenever we find a soft marker on ultrasound, a detailed ultrasound needs to be done to identify whether any other soft marker is present or any major structural malformation is present. Thereafter, we can counsel and the family, depending on the aneuploidy screening results, additional risk factors for aneuploidy, and also there are some non-aneuploid conditions which are associated with various soft markers. So depending on the condition, we can counsel the family. So coming to 1st trimester markers. So first of all, the most important is nuchal translucency. It is the most important marker in the 1st trimester for fetal aneuploidy. So as you can see, this is the fluid space between the back of the spine and skin in the fetal neck. So ideally, we should take at least 3 measurements, and the largest measurement that meets the criteria should be used for risk assessment. Also, the CRL should be between 45 to 84 millimeter, corresponding to gestational age of 11 weeks to 13 weeks, 6 days. The fetus should be in mid-sagittal position. The spine can be anterior or posterior. The image size, including the head and upper thorax, should occupy at least 2/3 of the screen. Fetus should be away from amnion. So this is the amniotic membrane and this is the fetal skin. Fetus should be in neutral position because when the fetus is hyperextended or hyperflexed, the measurement can vary. Also, if there is the umbilical cord is present in this area, then the measurement should be taken above and below the umbilical cord, and the average of 2 readings should be taken for final risk assessment. The caliper should be placed on the line. So this is the line for fetal skin and this is the line for spine. So caliper should be placed on these lines and maximum lucency should be selected for measurement. So increased NT is an indication for invasive testing and not for termination. Also, if fetal karyotype is normal, there is risk for certain non-chromosomal syndromes such as Noonan syndrome, certain lymphatic dysplasias. There is also increased risk for congenital heart defects and renal anomalies. So we should do detailed malformation scan and fetal echocardiography at 22 weeks. If both these scans are normal, then there are high chances of satisfactory outcome. Coming to second marker, that is nasal bone. So we have to see whether nasal bone is absent or present. So the standard view that is used for nuchal translucency is used for nasal bone also. But in this case, the fetus should face the transducer. The spine should be posterior. It cannot be seen when the spine is anterior. And also the angle of ansonation of should be 90 degree. So this is the fetal skin and this is the nasal bone. So other conditions are same, CRL between 45 to 84 millimeter mid-sagittal view. So these are the two echogenic lines. So this is the fetal skin. The first line is the fetal skin and the second line is the nasal bone. So this represents an equal sign. And this is the nasal tip. The third echogenic line in front of these two is the fetal nasal tip. In this, we cannot see the nasal bone, so only one line is visible here. The second line is away from this line, and this is the line corresponding to the fetal nasal tip. So in the image B, the nasal bone is absent. So next marker is ductus venosus Doppler. So as we know that oxygenated blood is coming from placenta through the umbilical vein and it comes through the ductus venosus. So the pulse is seen on the pulse Doppler as a forward flow throughout the cardiac cycle. There are some episodic changes that are corresponding to the various phases of the cardiac cycle. So the blood flow decreases during atrial contraction. So this is the A wave. So here you can see the A wave is present. So normally only forward flow is seen throughout the cardiac cycle, but when there is a reversal, here you can see that the A wave, there is reversal of flow at the area of A wave. So how to measure it, ductus venosus Doppler? So again, CRL should be between 45 to 84 millimeter, and the view should be in the mid-sagittal view. Thorax and abdomen should occupy most of the screen. Then we can see this is the umbilical vein, this is the ductus venosus, and this is the fetal heart. So for taking measurement, the gate should be small. It should be between 0.5 to 1 millimeter, and it should be positioned at the area of ductus venosus. So here you can see that only forward flow is seen. It is a normal waveform, and in the second image, the reversal of A wave is seen. So this can be seen in cases with trisomy 21. But we have to remember that reversal of A wave can also be seen in normal fetuses, but the rate is around 3% only. So A wave abnormalities are also associated with other abnormalities such as trisomy 13, 18, monosomy X, and also in cases of cardiac anomalies. Then tricuspid regurgitation. So it is seen in trisomy 56% of cases with trisomy 21 and in only 1% of euploid fetuses. Also, this can be seen in trisomy 13, 18, and monosomy X. This can also be associated with cardiac abnormalities. So to measure, we have to image the four-chamber heart view, and the fetus should be can be anterior or posterior. Like the face can be anterior or posterior. The thorax should occupy most of the screen. The gate should be large. In this case, it should be 2 to 3 millimeter, and it should be positioned across the tricuspid valve. So here you can see that this is the gate that we have positioned at the tricuspid valve. So in cases of tricuspid regurgitation, we will see a regurgitant flow, and the velocity of the regurgitant flow should be more than 60 centimeter per second. And the duration of this regurgitant flow should be more than 50% of the ventricular systole. So this is a normal image where no regurgitant flow is seen, and this is in image B, the regurgitation of fluid is seen. So coming to second trimester markers. So the most commonly studied markers of aneuploidy in second trimester are nuchal fold thickness, rhizomelic limb shortening, that is short humerus in short femur, fetal pylectasis, echogenic bowel, echogenic intracardiac focus, and choroid plexus cyst. So first is the nuchal fold thickness. So here you can see it is the space. It is the nuchal edema, which is measured in second trimester between 15 and 23 weeks. It was the first non-structural marker identified in relation to Down syndrome, and till now it is the single most predictive sonographic marker. Measurement is made in the transverse plane of the fetal head, slightly below the biparietal diameter. The section should include the cerebellum, the occipital bone, and the fetal skin. For measurement, the caliper is placed on the outer edge of the occipital bone to the outer edge of the skin. For comparing, the gestational age specific criteria should be used because nuchal fold thickness normally increases with gestational age. Before 20 weeks, before 20 weeks, 5 millimeter is taken as cutoff. So in any case, if NIPS or cell-free DNA testing is negative, no further test is done in case of increased nuchal fold thickness. If the patient has undergone serum screen which is negative, we can counsel for no further testing versus non-invasive versus invasive testing. So in any case, we have to give the patient all the options that are available, and it is the patient's prerogative whether she wants to go for invasive testing or for the non-invasive testing by NIPT. If there has been no prior screening, then also we will counsel for non-invasive versus invasive testing for aneuploidy. In this case, serial ultrasound examination for evaluation of the nuchal fold thickness is not indicated. In some studies, the association between congenital heart disease and thickened nuchal fold has been documented. But if cardiac anatomy has been visualized and is normal, no further imaging for that is indicated. Coming to echogenic bowel, so this is the echogenic bowel. So we have to compare it with the echogenicity of the adjacent iliac bone. So the echogenicity of bowel should be at least as echogenic as adjacent bone. It is present in almost 1% of all second trimester ultrasound. It can be seen in normal fetuses also. It is associated with aneuploidy, intrauterine growth retardation, intrauterine bleeding, cystic fibrosis, and congenital viral infections. So for seeing echogenic bowel, some technical factors are important. The frequency of transducer should be below 5 megahertz because high frequency transducers tend to overdiagnose echogenic bowel. And the setting should be at a lower gain. Again, it can be classified as focal, multifocal, or diffuse. A grading system has been proposed to quantify the degree of echogenicity to decrease the inter-observer variation. So Slotnick and colleagues have categorized into 3 grades. Grade 1 is echogenicity when the echogenicity is less than that of the iliac crest. Grade 2 echogenic bowel when the echogenicity is equal to the iliac crest, and grade 3 is more echogenic. The association of echogenic bowel with aneuploidy and adverse pregnancy outcome is increased in cases with grade 2 and grade 3 echogenic bowel. So in this case, detailed ultrasound of the fetus should be performed. If there is no prior screening, then non-invasive testing for aneuploidy by quad test or NIPT should be done. Cystic fibrosis carrier screening for both parents should be done, and maternal serological testing for CMV and toxoplasmosis should also be performed by measuring the immunoglobulin IgG and IgM levels. Then we should do serial growth scans because these fetuses are also at risk for intrauterine growth restriction. Coming to ventriculomegaly, the prevalence of ventriculomegaly is around 0.7%. In cases with ventriculomegaly, there is a risk of chromosomal abnormality. In cases of, if there is isolated ventriculomegaly, the risk of chromosomal abnormality is around 4 to 5%, which increases to 18.5% when there are associated malformations. Some cases may also be due to congenital cytomegalovirus. So maternal blood test for CMV and toxoplasmosis should also be done. Coming to another marker, that is short long bones. So individuals with Down syndrome were found to have short long bones compared with normal controls. So it is seen that around 25 to 50% of fetuses with Down syndrome have short femur, short humerus, or both, whereas in control population, only less than 5% of fetuses had short long bones. So how to diagnose? We have to see the ratio of observed to expected bone length. The expected bone length is calculated on the basis of biparietal diameter. So if the femur ratio is observed to expected ratio is less than 0.92, then it will be called as a short femur. And if the observed to expected ratio is less than 0.9 for humerus, then it will be called as short humerus. The predictive value of short humerus is more as compared to short femur. So in this case, if there is no prior screening, then we can counsel for non-invasive testing for aneuploidy by either quadruple test or NIPT. Also, in cases of short long bones, we should do detailed ultrasound to look for other bones also, because it can be associated with skeletal dysplasias. Also, follow-up imaging in third trimester ultrasound should be done for reassessment of growth, as this can be a sign of early intrauterine growth restriction. Then echogenic cardiac focus. So here you can see the echogenic cardiac focus. It is echogenic area. It should be less than 6 millimeter. It can be present in left ventricle or right ventricle. It should be as bright as the surrounding bone and should be visualized in at least 2 separate planes. Because in most of the cases, it has been seen that it is documented in a false positive manner. Also, it can be seen in up to 5% of normal pregnancies. Most common locations for identification are of false positive echogenic focus are moderator band, endocardial cushion, and tricuspid valve annulus. So we have to see for these spaces that echogenic focus should be present in at least 2 separate planes. In this case also, if there has been no prior screening, then we should counsel for non-invasive testing for aneuploidy. That can be either by quadruple test or by NIPT. Detailed echocardiogram is not recommended as long as the second trimester ultrasound is normal. So echogenic cardiac focus do not represent a structural or functional cardiac abnormality. We should do a detailed sonographic examination to search for any associated anomalies. If there are any associated anomalies, then they should be correlated with a priori risk. Amniocentesis need not to be offered in low risk patients that have an isolated echogenic focus. If there is any other major or minor sign present along with echogenic focus, then amniocentesis can be discussed. Coming to choroid plexus cysts, so these are small fluid-filled structure within the choroid plexus of the lateral ventricles. They are also seen in many normal pregnancies, and they can be present in 30 to 50% of fetuses with trisomy 18. When isolated, they are of no pathological significance. They can be isolated, multiple, unilateral or bilateral. When other anomalies are present, there is high risk of chromosomal defects, particularly trisomy 18. It does not increase the risk of trisomy 21 above the background risk. So we should do detailed ultrasound mainly for the fingers, and if there is overlapping digits or clenched fish, then the possibility of trisomy 18 is present. If fetal examination is normal, then the risk of trisomy 18 is very low. Also, in cases where there is no prior screening has been done, then we should counsel for non-invasive testing for aneuploidy, because in any case, the risk for trisomy 21 is always there. So aneuploidy screening should be offered. They are not considered a structural abnormality of brain, and nearly all of them resolve by 28 weeks of gestation. So when a fetus is affected by trisomy 18, usually we can see multiple structural abnormalities that can include structural heart defects, clenched hands, talipes deformity, growth restriction, and polyhydramnios. Coming to another marker, that is urinary tract dilatation. It is a common finding with an incidence of around 1%. So when the anteroposterior diameter of renal pelvis is more than 4 millimeter at 16 to 27 weeks of gestation, or when the renal pelvis diameter is more than 7 millimeter when the gestation age is more than 28 weeks. It may indicate renal or urinary tract pathology, or maybe a marker for trisomy 21. If no screening has been done, we should do a screening by quad test or NIPD. If there is no structural abnormalities or no other soft markers, then amniocentesis is not indicated. Sometimes there can be a progression of pylectasis, so third trimester ultrasound is indicated to identify the persistent cases. So, and urinary tract dilatation can be classified into two categories. It can be mild, which is known as A1, and it can be more severe in case of, then it is called as UTD A2-3. So when severe, the dilatation is more than 7 millimeter in 16 to 27 weeks gestation, and more than 10 in case of 28 weeks gestation. There can be collegial dilatation along with parenchymal thickness. There can be ureteric dilatation, or bladder wall thickness can be increased. So in these cases, follow-up ultrasound is indicated, whereas in case of mild dilatation, follow-up ultrasound is not indicated. We can only do a third trimester ultrasound after 32 weeks of gestation. So in antenatal management, we have to do persistent evaluation depending on the initial findings. And in mild dilatation, we only need to do third trimester ultrasound that will determine whether postnatal pediatric follow-up is indicated or not. So the common pathological causes that can cause urinary tract dilatation include vesicoureteral reflux, which is the most common cause. Then uretropelvic junction obstruction or uretrovesical junction obstruction. There can be multicystic dysplastic kidney that can be seen on ultrasound, or there can be posterior urethral valves. So some of these cases can be diagnosed antenatally, but usually the diagnosis is made postnatally. So at the time of delivery, the diagnosis should be communicated to the pediatrician. It has been seen that the mild cases usually resolve by the third trimester ultrasound examination, and they require no postnatal follow-up. Coming to single umbilical artery, so in this case, the umbilical cord contains one umbilical artery instead of normal 2. It can also be seen in 1% of all pregnancies. The incidence of single umbilical artery is increased in twin pregnancies. Sometimes structural malformations involving cardiovascular and renal system can be seen in these cases. Also, there is conflicting evidence that these can be associated with stillbirth or fetal growth restriction. So follow-up imaging in third trimester is required for evaluation of growth. In these cases, no additional evaluation for aneuploidy, whether previous screening test was done, was low risk or not done, is so no additional evaluation is indicated. Coming to absent or hypoplastic nasal bone. So how to define hypoplastic nasal bone? So the ratio of BPD to nasal bone is more than 10 or 11. The nasal bone is less than 2.5 millimeter in length, or less than 2.5 gestational age specific centile, or it is less than 0.7 multiples of median. It can also be present in euploid pregnancies in around 1% of cases. In case the NIPS has been done and is negative, no further test needs to be done. If serum screen has been done and is negative, then we can counsel whether the patient can go for no further testing. The patient can go for other non-invasive testing by NIPT, or patient can go directly for invasive testing by amniocentesis. Also, hypoplastic nasal bone can be associated with other genetic syndromes, particularly skeletal dysplasias. So the presence of these genetic syndromes should be looked for in further ultrasound examinations. So the next ultrasound marker is aberrant right subclavian artery. It has been seen that this is present in around 16% of infants with Down syndrome, whereas the frequency in general population is very low. So in normal fetuses, the right subclavian artery courses right and anterior to the trachea and esophagus, whereas in case of aberrant right subclavian artery, it crosses from the left thorax and behind the trachea. So when the RSI is present, we should do detailed ultrasound examination as well as fetal echocardiography. So this is the table which describes the likelihood ratio of each individual soft marker. So as we can see, the likelihood ratio is more in cases of absent of hypoplastic nasal bone, in case of aberrant right subclavian artery, increased nuchal fold, and ventriculomegaly, whereas in other cases it is less than 1 or around 1. So coming to aneuploidy risk assessment. So traditionally high risk for Down syndrome was told when the risk of aneuploidy was 1 in 270 or more. So 1 in 270 is the mid-second trimester prevalence for a 35-year-old woman. So this was initially taken as a high risk for aneuploidy. Amniocentesis was generally offered to those individuals whose risk was greater than 1 in 270. It can be based on advanced maternal age, maternal serum screening, or both. So these sonographic markers provide a method for further evaluating the risk based on the sonographic signs, and they refine the individual risk of having an affected fetus. So what is the importance of absence of marker? The genetic sonogram, which is detailed search for sonographic markers for aneuploidy, can be used to identify fetuses at high risk for aneuploidy. When normal, that is when no markers are identified, it can be used to provide decreased risk for aneuploidy. In patients with advanced maternal age, the absence of any markers is associated with decreased risk compared with the age-related empirical risk, and it has been shown that the risk is reduced by approximately 60%. What is the importance of presence of a marker? Sonography cannot be used to diagnose or exclude aneuploidy. It provides a non-invasive means by which we can adjust the a priori risk. So these a priori risks can be based on maternal age, gestational age, and serum aneuploidy screening. So if there is more than one abnormal finding on ultrasound, if the patient is older than 35 years of age, or if multiple marker screen is abnormal, means quadruple test or dual marker is abnormal, amniocentesis should be recommended to rule out aneuploidy. So what are the current recommendations? A final risk estimate incorporating the presence or absence of ultrasound soft markers was initially used to counsel a patient on the risk, for the risk of aneuploidy. However, the relative importance of this approach has evolved rapidly with involved prenatal screening techniques. With the current use of cell-free DNA screening, that is NIPT, the relevance of a soft marker finding has changed, because when we are doing NIPT and the result is low, the post-test probability of a common aneuploidy, that is Down syndrome, is very low. For instance, after a negative NIPT result, the risk of trisomy 21 is reduced by approximately 300-fold. So historically, the testing was offered only to patients considered at high risk because of maternal age or personal history or family history. But according to the current guidelines from American College of Obstetricians and Gynecologists and Society of Maternal Fetal Medicine, serum screening, that can be serum screening with or without NT or cell-free DNA screening, as well as diagnostic testing, which can be by CVS or amniocentesis for chromosomal abnormalities, should be discussed and offered to all patients early in pregnancy, regardless of maternal age or baseline risk. No diagnostic testing for aneuploidy solely for an isolated soft marker should be recommended. If a patient has undergone diagnostic testing and the result is normal, then identification of a soft marker is insignificant and it should be reported as such. For pregnant females with no prior aneuploidy screening, if we identify echogenic cardiac focus, echogenic bowel, urinary tract dilatation, or shortened long bones, then counseling is recommended to estimate the probability of trisomy 21. We should discuss options of NIPT, quadruple test, if NIPT is unavailable or cost is prohibitive. But if we identify thickened nuchal fold or absent or hyperplastic nasal bone, then we can discuss the option of amniocentesis as well, along with quadruple test and NIPT. If the patient is coming with negative serum screening and the ultrasound is showing isolated thickened nuchal fold or absent or hyperplastic nasal bone, then also we can discuss the option of amniocentesis as well as serum screening. But if the patient is coming with negative NIPT report and on ultrasound we are seeing isolated thickened nuchal fold or absent or hyperplastic nasal bone, then no further aneuploidy evaluation is indicated. For fetuses with isolated echogenic bowel, evaluation for cystic fibrosis and CMV infection and a third trimester ultrasound examination is recommended for fetal growth. So with advances in prenatal screening for fetal aneuploidy, the relative impact of soft ultrasound markers in assessing the risk of aneuploidy has decreased. When an isolated soft marker is identified after negative screening result, patient may be reassured that the risk of fetal aneuploidy remains low. However, identification of soft markers is important to evaluate for associated conditions that are unrelated to fetal aneuploidy. Thanks for patiently listening.
Thank you, Deepti, that was wonderful. I know you are a dysmorphologist, so obviously you would have had a detailed account of everything, and you might be seeing patients also sent for counseling and all. But at the same time, being an obstetrician is a tough job, because all the time we keep talking of percentages, but at the same time, we do not know for that particular patient. If we say it happens, then for her it is 100%. So that's a practical difficulty we face every time. And we know 0.1%, 0.9%, all these things, how much importance to give to these soft markers is always a tough job. But as she has also put ahead that there are several soft markers, say about 15 to 20, and obviously everything we cannot take seriously, and every marker perhaps we cannot overlook also, and therefore, and all these problems probably we are facing more these days because of an increased accuracy of the ultrasound machines. High-end machines have come up, so obviously they are detecting more and more anomalies, and because of these markers, again, when we tell the patients there is some report on the markers, obviously we are held responsible if something comes out wrong at the end. Now we know these are all soft markers, these are all isolated, and then they are also, some of them are even transient. So definitely there is a big gray zone. After the NIPT gray zone, I think we are also quite not very clear how much importance to give to these soft markers. But at the same time, when an ultrasound report has come with these markers, it is also not easy for us to keep telling them that just do not worry, they are just there, and maybe they will disappear or they do not have importance. But as we all know, isolated markers, single soft markers, probably we can watch them, and a good anomaly scan. Again, here, there is a big importance for a good ultrasonologist who can really differentiate every bit of it. And luckily for us in Chennai, we do have a very good center with Mediscan, and we do have very good consultations and ultrasound opinions and dysmorphologists. And therefore, we are spared quite a bit in trying to counsel these patients. But as you said, as we move ahead in pregnancy, from second to third trimester, perhaps a good ultrasound scan, and also whether these lesions are progressive, especially in cases of the pelvic dilatation, pelvic-tasis, pylectasis, or even for the long and short bones. I think those measurements can definitely be followed up, and if becoming more, we can definitely counsel. In fact, I had one of the patients who had just ventriculomegaly, and that was in fact not increasing, it was within the range, and we counseled that it's fine, it's a single marker, there is nothing. After delivery, when the baby, second day, normal delivery, no issues, uneventful pregnancy and delivery, but at the end of the delivery, on the second day, she threw fits, the baby threw fits. Then there were some ventricular hemorrhages in the cavity, in the ventricle. So again, we were put back to the same question, whether what was seen in the ventriculomegaly, whether we could have given a little more importance. Of course, these hemorrhages are a different entity, but at the same time, this is kind of a scenario where a soft marker is presenting, and we keep convincing them, but postnatally we do face a situation where we need to explain them a little more. And obviously all the time counseling sessions are important, and we know nothing can replace the counseling, and just being very friendly, very close to the patient, try to share that this is possible, and the scientific evidence is suggestive, guides us, but at the same time, sometimes we are taken aback. I think she has given a beautiful description of all the markers, and whether how much importance we can give based on the NIPT or based on the quadruple screening, and whether most of them, I think we need not do an amniocentesis, but at the same time be guarded when you are counseling them. Of course, with the echogenic bowel and all those things, sometimes we have faced difficulties, and there have been some postnatal diagnosis as well. And of course, a CMV screening and toxoplasmosis screening and growth restriction observations we have been doing. Single umbilical artery, I think, is not that uncommon, and we do come across, and a good prognosis comes on when there is a growth restriction issue. This is what I feel, and over to Sadhana and Dr. Kuthe for further observations and opinions. Thank you very much, Sadhana, for including me, and I was really thrilled when you brought me into this particular communications and conversation, because I know it is tough. Every day in and day out we manage, but at the same time, we have to be really lucky at the end of the day. Thank you, Sadhana, for giving me this opportunity, and thank you, Team ISOPARB.
Thank you, Deepak, for a good compilation, and thank you, Vijaya, for very ground realities, which is close to our heart, that what we should do with the patient who is sitting in front of us. So I think 2 or 3 points we have to be very, very clear, that the first is the isolated versus multiple. That makes our track totally different. The second thing is the low risk population versus high risk population. That is also important, because in the elderly age, or in which there has been some history, even a one isolated marker, we should take it with a quite bit of caution. And thirdly is what is the association with the first trimester screening, because first trimester screening is negative, that it makes we take the different pathway. A fourth thing which we want to give very, very carefully, that few things like ventriculomegaly, then echogenic bowel, where we have to consider is still the torch infection, especially toxo and the cyto. And in our country, we say torch ko humne bahut aage badhaya, fir ekdam bujha diya, but in bad obstacle history in India, where there is a lot of the close gathering, low socioeconomic status, we should consider this toxoplasma cytomegalomy. It is not to be thrown away. And fourth is what we say association. Like if it is choroid plexus cyst, usually no developmental delay, but we should have a good look at the hand. If there is a nuchal thickness, if everything is normal, even then we have to do for something for the heart. And I will like to say from Deepak that if nuchal fold thickness is considered one of the very important markers. And the third is that how to follow echogenic bowel. We have to see for growth insufficiency. It is not only, it is the growth retardation and post-operative also issue. Ventriculomegaly, even if it is isolated, even if low risk case, we have to be careful about developmental delay. So it is a picture. Soft marker, we cannot say NIPT is negative. That will give indirect message to do NIPT again, then everything is fine. Soft marker also says something very, very important. This baby needs follow-up. We will have the pediatrician comment. This baby needs post-neonatal follow-up. This baby needs viral infection and the aneuploidy. Of course, I will say low risk versus high risk, isolated versus multiple. These are the issues which we have to be very, very careful, because both group have got the different roadmap for the follow-up care. So Alka, you are expert in medical legal, and Vijaya also did. Everybody is concerned about the legal issues today. So Alka, and you are just 1 year back junior to me. You were proudly 1977 batch. Yeah. So for your legal inputs, how we should safeguard ourselves.
Yeah. At the outset, let me thank Dr. Gangadhar Sahu, President ISOPARB chapter, and especially Sadhana Madam for involving me in this webinar. Actually, we are meeting online only. We have not seen each other since many years, but I will come to your city or Patna, because I was there in Patna. Dr. Mishra was there, Senior Mishra Madam. She had invited me for one lecture, UNICEF. Okay, depending upon the circumstances, what I saw through the literature, most of the studies are based on high-risk pregnancy. So it becomes totally illogical to apply this study to low-risk pregnancy. So there should be some prospective study which will apply to the low-risk population, so that we can consider it valid so as to go for invasive techniques. Regarding medical point of view, what I think everything depends on counseling and communication. when patient comes to us, especially IVF pregnancy, they come to us obstetrician, and the age factor is important, family history is important, whether she is diabetic, all these things are important. But the thing what is left to us is counseling, communication to the patient, because she is from a family where there is some congenital anomaly, she is from a family where mother is diabetic. All these things we relate with the maternal age, and that time we had to take the signature of the patient, that we are informed that these are the things like NT scan, double marker, and triple marker we are left nowadays, quadruple marker, and depending upon the this non-invasive technique, whether she needs any invasive technique. Because what happens, suppose somebody said that we should not order. I like the word order. We should offer the test. So offer the testing is very important as per medical point of view is concerned, and not just tell orally. Whatever we communicate to the patient, we should write down on the patient's paper, whether it is a OPD card or indoor card, whatever. Because what happens, sometimes there is isolated soft marker is there. Now we have discussed that Dr. Dipti Saxena has did a wonderful lecture. She has gone through all the soft markers, isolated and combined. Out of that, ventriculomegaly, nickel fold thickness, aberrant right subclavian artery, all these things, echogenic bowel, all these things have greater likelihood ratio. They calculate likelihood ratio more than 1, somewhere 3, like that. So if they have isolated soft marker, but there is a chance of getting the baby affected. So we must write down, we must counsel to the patient. So these are the risks that baby may get affected. So go for invasive technique. Sometimes the patients are afraid of going for invasive technique. So we write down on the paper, patient not ready for invasive technique, because invasive technique is confirmatory technique. We can confirm everything by CVS sampling or by amniocentesis. The patient is so afraid of going for all this technique. She's denying that I don't want to go for, because single soft marker is there. But we can understand what is meant by ventriculomegaly, what is meant by right subclavian artery, aberrant right subclavian artery. So we should tell then and there only, because this is the chance of baby getting affected, though this is a single soft marker. Because sometimes what happens, we obstetricians just forget, oh, there is only one soft marker. So let us forget that. But sometimes what happens, these are all screening tests, they are not confirmatory tests. So we should always go for invasive technique, at least advise there, and if the patient relatives not want, write down there only. Again, there is anomaly scan, which is non-invasive technique. Anomaly scan can be done. Nowadays, we know that MTP Act has been amendment. So up to 24 weeks, we can terminate the pregnancy. So this chance should be given to the mother, because she is carrying anomalous baby. For that, she is having some mental mental trauma and everything related to that anomalous baby. So if we carry out 18 to 22 weeks scan, anomaly scan, and that also can be given, can give you idea about the anomalous baby. So what I am telling, as far as medical point of view concerned, we should offer all the available, though it is costly, we should not take care about patient's pocket. We should take care about our own safety. Many times what our patient about, bichara garib patient, bichara never say bichara. She will tell doctor, if you had offered me this testing, I would have gone for this testing. So don't say bichara. Every patient is that much wise to go for the invasive technique. Only thing is that sometimes they are afraid of that technique. So we have to counsel, explain what is meant by invasive technique. And only 1 to 2%, I think 1% mortality, fetal mortality with that invasive technique. Some claim even less than 1% fetal mortality. So we should all think, we should tell all these things related to invasive technique. And even if that, in spite of that, patient says, no, madam, I don't want to go for invasive technique, write down there, take the signature of patient and some witness. So if something happens in the future, because she had not undergone invasive technique, amniocentesis, then we can say, see, I had offered you this testing because there was ventriculomegaly, because there was aberrant right subclavian artery, because there was echogenic bowel, but you said, no, madam, I don't want to test for all this. So again, coming back to the old ultrasound, gold standard ultrasound, if the patient is not ready for invasive, at least do anomaly scan and advise anomaly scan on the OPD paper. Don't say USG obstetrics, right? Clear cut anomaly scan to exclude anomaly, as there is history of anomaly in the family, or she's a diabetic case, or maternal age more than 35. All these things will save us medically if the patient goes into court of law. Sometimes what happens, that time patients are very emotional. Mother is there, no, madam, तुम्ही आप कहोगे वही सब ठीक है. आप कहोगे मतलब हमारे ऊपर डालते, आप कहोगे तो जाएंगे, आप कहोगे तो नहीं करेंगे, whatever आप कहोगे तो. So this आप can be dangerous for us in the future. So every patient is potent litigant. This word is very important, potent litigant. So whatever test you can offer, always offer all the spectrum of tests. And if the patient is not ready, take informed refusal. And if the patient is ready, even if the test becomes negative, no harm in doing invasive technique also, because there is least fetal mortality. But if we are afraid of taking advising the patient because it is costly for the patient's pocket, no, not at all. So always go for standard protocol, at least for anomaly, for history of anomaly in the family. Patient is diabetic, maternal age more than 35, because what happens nowadays, these girls get married very late after their career. So first primary, she's 30 years old, and she wants second child after 5 years, she becomes 35 years old. So there are certain risks associated with maternal age. We calculate with double marker test and quadruple marker test, again NIPT, all these are there. But unless and until we tell this patient, explain them, so counseling, communication, documentation of the communication, all these things will help you in the future. If there's some anomaly and the patient or relatives go, because IVF pregnancy, imagine if IVF pregnancy is there and you are not said anything about the invasive technique, if there is a ventriculomegaly, that subclavian artery is there, or echogenic bowel is there, or even nuchal fold thickness is very important in the high risk group. So if you advise, and if something is there, even if in IVF pregnancy, it can protect you in the court of law. So that's my advice. Always offer all the tests. वहाँ कंजूसी नहीं करना है. वहाँ कितना भी आपको आप बोला तो समझ लेना है. She can be, अभी तो स्वीट बोल रही है, आपसे मीठा बात कर रही कि फ्यूचर कुछ भी हो सकता है आपके साथ में. So always think each and every patient as potent litigant and offer all the tests whatever possible. Don't think about patient's pocket. Think about your safety. Thank you, ma'am.
Yeah. Dr. Alka, I just had one question. This is Dr. Rekha Rajendra Kumar. Agreed that all patients are non-becharas and future litigants, everything. Example, suppose a patient comes with only one soft marker, say like a perineal pelvic diameter of 7 mm, borderline, or no other problem, or a single umbilical artery, whatever. What you want me to do? Directly advise them to amniocentesis, or what you want me to do?
No, madam. There are some markers like this choroid plexus that disappears most of the time at 20 weeks of gestation, like this single umbilical artery, or some there are wide short femur. Short humerus is more important than short femur. So there are certain soft markers. Independently, they are not so important. But independently, if there is right subclavian artery, aberrant right subclavian artery, or if there is ventriculomegaly or echogenic bowel, these are the markers. They have more than one likelihood ratio. So the markers, soft markers, even if they are isolated, but they have related with maternal age, of course. If they have more than one likelihood of or ratio of getting the baby anomalous, for them even a single marker, we should go for invasive technique.
Okay.
What I said, madam, we should offer the test. The word is correct. Offer the test. If she says, no, madam, ये तो क्या सिर्फ इतना सा आया है मेरे से.
Offer मतलब amniocentesis only advice? Direct?
Yes. Okay. Already she has undergone NIPT test. She had done double.
She has not undergone. If she is not.
I think Alka, a little. We will like to hear from Deepthi. I will say that not for every test. It is a clear recommendation that few isolated markers are quite benign, like choroid plexus. It is not a thing. Single umbilical artery for something like nuchal fold thickness more than 5. Then the short, long bones. Few soft marker are important and they warrant invasive testing because frightening too much because we are fearful and patient is fearful, and that makes a very important. So Deepthi, your comment. I think for every soft marker, it was not your message.
Yes,
ma'am.
We should offer the combined likelihood ratio. That is calculated by our softwares. We have Astraya, and our softwares are giving combined likelihood ratio. And according to that, we should
incorporating all the software. I would like to make. साधना मैडम, पहले कैसा जमाना था, 5-6 बच्चे रहते थे, उसमें से 2-3 जाते थे.
मैंने नहीं कहा, मैंने कहा कि मेडिकल लीगली भी every marker don't have that same importance.
अभी कैसा है, 2 ही बच्चे अच्छे होना है, 2 बच्चे अच्छे होना है. And that also
Medically, we are safe when we follow the recommendations given by various bodies. And let Dipti elaborate what does she want to.
Yeah, because if you directly advise amniocentesis, also you may be legally liable.
Yes.
That is why I'm asking.
1% mortality, I think it is less than 1, but 1% is too high. My IVF pregnancy, they did send for fetal reduction to Dipti Institute, and when they explained that it is reduction, they come back. We don't want to, no, 1% is too much for a, like, it's
Yes.
a Dipti, your comment, different,
Dipti, what do-
different marker, different, like.
So we have to decide according to the marker, like in case of increased nuchal fold thickness or ventriculomegaly, besides Down syndrome, there are some other chromosomal abnormalities that can also be present. So first we should offer amniocentesis along with chromosomal microarray so that we can detect all the detectable chromosomal abnormalities. But if the patient refuses for amniocentesis, then second option, we can go for NIPT. Like it can exclude most of the Down syndromes that can be seen. So if the patient is not ready for NIPT also, then the next option is quadruple test. But we should explain at each point that as the sensitivity of the test is decreasing, then the chances of abnormality remaining in the fetus will increase. So accordingly, like if in case of echogenic cardiac focus, choroid plexus cyst, single umbilical artery, only a negative quadruple test is sufficient. So in that case, we need not do anything else.
Likewise, Dr. Deepti said, we also mentioned similarly that for that matter, if single umbilical artery is present, it is associated with genitourinary and cardiac abnormality. If those has been ruled out and the quadruple marker is normal, we say that it has a sensitivity of 80%. It cannot be 100%. We cannot order diagnostic testing to all the cases, but we have to mention that single umbilical artery is associated with so and so, and it has been ruled out. Quadruple marker is normal. So we have ruled out Down syndrome with a sensitivity of 80%. So this thing should be mentioned. Amniocentesis cannot be offered to all the cases, but anyways, we have to mention the sensitivity. Even if everything is normal, then also the babies with the Down syndrome can be born because all these are screening tests. So it should be documented, whatever test. For that matter, with the intermediate risk, also the baby with the Down syndrome can be born. So I usually mention that it has a sensitivity of so and so percent, and it has been ruled out with so much sensitivity.
So the patient asks, what about the rest 20%? Then what do you do?
So I tell the family, because the guideline says, the ACOG and the ACMG guidelines says, if the patient wants 100% answer, then we can offer diagnostic testing. If the patient is willing, aapko kya lagta hai? We can tell them that most probably the baby is going to be normal, but we cannot offer amniocentesis to all the cases. If the patient wants, with the intermediate risk, also the patients come for amniocentesis. If the patient is willing and is willing to take the risk of miscarriage of 0.2%, then we can offer amniocentesis. The guideline says that diagnostic testing can be offered if the family wants 100% answer.
So, madam, what I have seen is, I have sent 3 or 4 patients of intracardiac echogenic focus and single umbilical artery to fetal medicine center. But then they investigated the patient with amniocentesis and then they sent back to me. Like no one is leaving it over there. That's what I have seen.
Actually, with 2 ultrasonographic soft markers, the risk is increased.
That is an indication for amniocentesis.
Actually, madam, what I told, 80% sensitivity is okay. We can tell to the patient, but if the patient says, I don't want even a 20%, a single percent.
Then it can be offered.
Yeah.
Then you offer the test.
100% answer, then it can be
कराना ही पड़ेगा. जो 100% वाले तो आपको हमेशा ही परेशान करेंगे. लेबर में भी परेशान करेंगे.
100% जो भी चाहिए वो नॉर्मल प्रेगनेंसी में सब कुछ नॉर्मल के बाद भी करना पड़ेगा.
नॉर्मल के बाद भी सिंगल जीन डिसऑर्डर हो सकता है.
Likelihood ratio will depend on that. Likelihood ratio, अगर multiple factors likelihood ratio will increase, and if it crosses the borderline, then you do an amnio. If it doesn't, then don't. You have to give a printed report to the patient. This is the likelihood ratio. If you want to go ahead for amniocentesis, this is the best option. If you don't, then this is the risk, and you will face a problem. You can face a problem. So this likelihood ratio should be calculated. All multiple factors, the risk increases every time you add a factor.
I will say जो 100% वाला crowd है ना, वो तो कभी ना कभी आपको फंसाएगा कि आप सीजन करो चाहे बच्चा
That's what is like.
So that is the crowd.
Yeah, totally.
If not on anomalies, even with the obstetric purposes, they can put you in 100%.
We can tell them that सुनो ज़्यादा chance है कि नहीं कुछ होगा, but we cannot say 100% सब कुछ ठीक होगा. and this risk you have to take, otherwise you go for this test.
Otherwise you go for
if they go ahead with amniocentesis, then also there is a 3 to 4%
And we tell them
genetic disorder.
पेशेंट को थोड़ा टाइम दो ना तो समझ जाता है. We tell them ऐसे बहुत सारे केसेस का टेस्ट कराते हैं हम लोग, सबके बच्चे नॉर्मल निकलते हैं. मे बी यू आर द सेम, लेकिन हाँ 100% हम कह नहीं सकते.
That is नॉर्मल निकलते हैं. दूसरी बात ये कि लाइक वन मैसेज काउंसलिंग के लिए बहुत है, लेकिन इट शुड बी लाइक ना कंफर्टेबल एंड अ फ्रेंडली जोन. ये बहुत डरा हुआ नहीं,
पैनिक नहीं करना चाहिए. पेशेंट हमेशा रिपोर्ट लेके पैनिक ही होके आता है, और एक पेशेंट तो ठंडे होके आ जाते हैं, बिल्कुल ठंडे. So much scared of the report.
Madam, what did you say that 4% if amniocentesis is done, there is 4% chance of कुछ आपने बोला, I could not catch that point.
Ma'am, 3 to 4%, because if everything is normal, if you go ahead with amniocentesis and even get the microarray done, there is a background risk of 3 to 4% of any genetic disorder. It can be DMD, SMA, or any genetic disorder. That cannot be ruled out even if we go ahead with
पेशेंट को ऐसे समझाना चाहिए कि अब देखो जितना कुछ है सब हम लोग टेस्ट कर ही नहीं सकते हैं. जितने टेस्ट हमारे पास है उतना हम कर देंगे, उतना हम बता देंगे, बाकी तो भगवान के ऊपर.
जो बेस्ट ऑप्शन है आप दीजिए उसको. Best option available right now.
Come from court to God, क्योंकि भगवान पे आना ही पड़ता है लाइफ के लिए. बबीता, we can start the next session. Wonderful discussion.
Madam, only one question I had. Dr. Moni, which are the cases where you directly advise amniocentesis? Which are the soft markers? Name few. Because you told me that certain, like say echogenic bowel and all, don't go for amniocentesis as the first place. Abhi, which are the ones which you will directly tell me to go for amniocentesis? Patient will leave it on me. I agree.
Absent nasal bone, increased NT, absent nasal bone. This has a very high likelihood ratio. 1 is to 7 to 8, which is a very high likelihood ratio. So hypoplastic nasal bone, there is nothing like hypoplastic nasal bone in the first trimester. It is either absent or it is present. So if it is absent, then go for an invasive testing. 100% go for an invasive.
Aberrant right supply artery, that is also indication. Dipti, aberrant.
No, ma'am.
Aberrant may
the likelihood ratio was very high, but recent studies have shown that the likelihood ratio is not so high as predicted earlier. So for now, yes, nuchal fold thickness, ventriculomegaly, and hypoplastic nasal bone, increased nuchal translucency are the indications for invasive testing.
And 2 soft markers if present, those are often.
Madam, last word, what I was telling, it depends upon the counseling. So whatever you were telling, no, there is 100% chance of they nahi sakte. Again, there is 4% chance of anomalous baby. So these things come under counseling. So unless and until the counseling, we tell 80% sensitivity, etc. Patient will get satisfied, and then she can go for, if needed, for invasive. Directly to invasive, हम कभी बोल भी नहीं सकते, बोलेंगे भी नहीं, because we have to do a lot of counseling in our OPD. Then only the patient goes for further testing. And that also depending upon our broad approach. If singly we tell you this test you have to do, she will never go for testing. So counseling and communication. Then only we can advise for the further testing. Otherwise, if you don't counsel, you don't write on the OPD paper that I had counsel, anything can happen in the future. But there is again 4% chance of anything.
80% counseling, 20% practice.
So we can conclude now session. Babita, who is going to take the next session? A wonderful discussion.
Thank you.
And
thank
I hope.
Thank you. Yeah, because it can go on and on and on.
Yes,
Thank you.
After a wonderful discussion, we now move on to our third session, suspected congenital anomalies in third trimester. And for this session, we have with us very learned and experienced experts to share their knowledge and experience with us. I would like to introduce, may I have the CV please? Nisha? Dr. Rekha. Dr. Rekha Rajendra Kumar, she is gynecologist and IVF specialist. Ma'am has achieved 13 awards and 3 felicitations, including 1 international and 3 state awards. She has graced many posts: Vice President, BSOG 2022 to 2023, past Honorary Secretary, BSOG, South Zone Coordinator, FOXY Infertility Committee, Chairperson Infertility and ART Committee, KSOGA 2020 to 2022. She has been speaker, chairperson, moderator, panelist in more than 500 state, national and international conferences, life member, BSOG, FOXY, SAR, HISAR, IAG, PCOS Society of India, Karnataka Cancer Society, committee member of Infertility Workshop. Many papers and publications goes to her credit. Ma'am has given more than 100 radio and television talks. Welcome you, ma'am.
Thank you, Dr. Aruna. Thanks
My
for
pleasure.
the welcome.
Now, our most dynamic and excellent organizer, Dr. Reena Srivastava, ma'am, ex-professor and HOD, BRD Medical College, President UP Chapter and of Ops and Gynae, President Gorakpur Menopause Society, authored chapter in many books. Ma'am has also graced many posts, HOD Ops and Gynae, Treasurer Secretary.
Time late हो रहा है. चलो जल्दी करो.
So thank you.
Thank you for nice words.
Next, please. Dr. Sunil Kamani, a renowned pediatrician and neonatal consultant, past president of Gorakhpur Association of Pediatrics, trained breastfeeding and counselor. Welcome, sir. And the speaker for this session is Dr. Shikha Agarwal, a young fetal medicine specialist from our Gorakhpur city. Shikha has done fellowship in obstetrics ultrasound medicine Chennai, fellowship in fetal medicine Paris Ahmedabad, Best Paper Award Recon 2014 she has received, and also for the Best Poster Award. Welcome Dr. Shikha for your deliberation. Dr. Shikha. Dr. Shikha?
Can you see my screen, ma'am?
No, not yet.
You are visible, Shikha.
Screen is not visible. Yes, your slides can be seen now.
Thank you, ma'am. Respected seniors and dear friends, at the outset, I would like to thank Dr. Sadhana ma'am and the organizing committee to give me this opportunity to interact with such a learned audience at such a great platform. Thank you, madam. So we are here to discuss anomalies that first appear during the third trimester and a nightmare for the obstetrician. So, fetal anomalies detected during the third trimester. The routine third trimester scan is increasingly offered for growth anomalies and presentations, but nevertheless, there is an ongoing debate whether to do a routine pregnancy scan in low-risk population. Anomalies detected in the third trimester can be classified into two groups: those which were present earlier but not detected in first and second trimester screening, and anomalies that develop or manifest only in late pregnancy and could not have been reasonably detected earlier. Anomalies which were present earlier but not detected could be because of unfavorable maternal habitus of fetal life. They can be overlooked by a screening sonologist, or they may be small and appear larger during the third trimester, like in case of ventricular septal defects. Abnormalities that can only be seen with the fetal maturation are certain malformations of cortical development like microcephaly and hydrocephaly, GIT anomalies like intestinal obstruction, urinary tract anomalies like renal pelvis dilatation, ventriculomegaly, hydrocephalus in the third trimester, skeletal dysplasias, and cardiac anomalies like ventricular septal defects. The aim of this study is to establish the prevalence and determine the type of malformations, chromosomal, genetic, and structural, that are detected at the time of routine third trimester ultrasound screening for fetal growth in populations with adequate prior screening. In this meta-analysis, around 1,41,717 cases underwent a routine third trimester scan were taken, and 643 were found to have congenital anomalies straight in the third trimester. That is, around 1 in 300 pregnancies had anomaly in the third trimester, even after a first and second trimester screening. The genitourinary anomalies like renal pelvis dilatation are the most common. Second most common are CNS anomalies like ventriculomegaly. Next are the cardiac defects like ventricular septal defects. There was another study which said that a routine third trimester scan will detect 1 in 200 pregnancies. There was another study which said that prevalence of anomalies detected in those that undertook a growth scan only was 1.5 per thousand, while with repeat anomaly scanning, it was 3.7 per thousand. So what we need to do is not only a second trimester anomaly scan. We have already started with a first trimester anomaly scan. We do a second trimester anomaly scan, and we are on the verge of saying we also need to do a third trimester anomaly scan. The urinary system, growing kidneys increase in function, produce more urine, and hence pathologies not evident previously can be unmasked. These pathologies can be like renal pelvic dilatation, duplex kidneys, absent single kidney, ectopic kidney, ovarian cysts, and hematocolpos. Ovarian cysts manifest later because of maternal estrogenic stimulation. Now, these are images of renal pelvis dilatation. Pelviectasis is a very big confusion for the obstetrician. But as Prashant sir used to say, by the rule of thumb, you measure the renal pelvis in this bang anterior or posterior section. And if the measurement in millimeter is more than the number of months of the corresponding pregnancy, then it is to be taken care of, otherwise ignored. So, like if the gestational age is 24 weeks and the renal pelvis diameter is 7 mm, then 24 weeks pregnancy corresponds roughly to a 6-month pregnancy. The 7 mm renal pelvis diameter is more than 6 months. So this is to be taken care of. Anything less than this is not a reason to worry. These are bilateral renal PUJ obstruction that we see here. This is not a case of lower urinary tract obstruction as was referred to me. The bladder is small, the walls are thin, and there is no ureter dilated in between the renal pelvis and the bladder. These are pelvic junction obstructions seen in unilateral kidneys. What we do in antenatal hydronephrosis, in a unilateral hydronephrosis, we do ultrasound in the third trimester. That is, we follow up the patient, and postnatally, we do an KUV ultrasound at 3 to 7 days, and this should be repeated at 6 weeks. Bilateral severe hydronephrosis, we also do serial ultrasound monitoring every 2 to 6 weeks, and postnatal ultrasound should be done within 48 hours of birth. But if there are other soft markers, genetic counseling and prenatal testing comes in. Now, this was a duplex collecting system recognized in the third trimester, and this is an image of a horseshoe kidney I have taken from the Fetal Medicine Foundation. The video is coming skewed, but I can't help it. So I have already shown you the image of the horseshoe kidney. This is an ovarian cyst manifesting in the third trimester. Now, this is the bladder. This is the stomach. Any cystic area between the bladder and the stomach is an anomaly. It can be an abdominal cyst, a mesenteric cyst, or it can be ovarian cyst, most likely in a female fetus. So in ovarian cyst, you can see daughter cyst, and that is most predictive of an ovarian cyst. Ambiguous genitalia. Now, if it is an ambiguous genitalia, half the time we don't know whether it is a female fetus or it is a male fetus. So in the case of a female fetus, the genitalia are parallel to the spine, while in the case of a male fetus, the penis will be at an acute angle to the spine. Other findings are a cleaved genitalia. Cleaved genitalia is very characteristic of female fetus, and the phallus is very characteristic of a male fetus. Here it is a male fetus, and this is the phallus which is cleaved. This is an ambiguous genitalia. This is the hypospadias of the penis. Central nervous system anomalies, ventriculomegaly, mild, moderate, and severe can appear anytime. And can pose problems. Neural tube defects, arachnoid cysts, anomalies of cortical development like microcephaly, macrocephaly, lyssencephaly, anomalies of corpus callosum or vermis formation. Then craniosynostosis, the abnormal shape of the head will appear only late when the head starts growing in the third trimester. Besides these, stroke, hemorrhage, infection, and tumors are other causes of CNS anomalies. Now, for knowing ventriculomegaly, what we need to do is to accurately measure the ventricle. How do we do that? Now, this is the parieto-occipital suture, and perpendicular to it, from inner to inner, we measure the ventricle. If this is more than 10 mm, then it is mild ventriculomegaly, 10 to 12 mm, 12 to 15 is moderate, and more than 15 is severe ventriculomegaly. In case of ventriculomegaly, we have to rule out chromosomal causes and infectious causes, as was previously discussed by Dr. Deepti. Ventriculomegaly, this is third trimester ventriculomegaly in two fetuses. This was an open fourth ventricle or a keyhole shape that we saw, and this was the corresponding sagittal image with a tail-shaped vermis. Now, this is the normal vermis in the corresponding gestational age, which is appearing more like a bean shape, but this is a tail-like vermis, and so this is dysmorphic vermis. While anomalies like alobar holoprosencephaly can be diagnosed as early as at 11 weeks, anomalies like lobar holoprosencephaly and semi-lobar holoprosencephaly can appear later on and can pose challenges in diagnosis. This is an image of a Dandy Walker malformation. If we see this plane, we feel it is a normal cerebellum. But when we angulate and see, then we have seen that it was the vermis is absent, and this was a hyperplastic vermis. Cardiac cases like VST, valvular stenosis like pulmonary and aortic valve stenosis, arch anomalies like coarctation, interrupted arch hypoplasia, rhabdomyomas, aberrant right subclavian artery, and persistent left SVC can manifest later in third trimester. VSTs can be broadly classified into three categories: inlet, muscular, and perimembranous. Inlet, besides these, we have subaortic and subpulmonic VSTs also. This is a VST with an overriding aorta, and this is a muscular VST. These are images showing an aliasing in the aorta, and this was more than 200. It was more than 200, and so it was aortic stenosis. Similarly, this is the aliasing seen in the pulmonary artery in both the images, and this was a jet that we saw, and this was again pulmonary stenosis. This was pulmonary stenosis which had progressed to absent pulmonary valve syndrome in the third trimester. And this is images of the coarctation of aorta. How do we doubt coarctation of aorta? Coarctation of aorta is a very difficult diagnosis. And in the second trimester, we see a narrow aortic caliber compared to the pulmonary artery. We should follow up with Z-scores. This is a right-left chamber asymmetry, and this is the aortic arch, which is becoming thinner here. And this was coarctation of aorta. What we study is the shelf side, which is characteristically seen in coarctation of aorta. Interrupted aortic arch. The arch here is deficient after the left subclavian artery. This is an animated image of the interrupted aortic arch. And this, again, the aorta is very small compared to the pulmonary artery. Compared to coarctation, the aorta in interrupted aortic artery is distinctly small, and chamber asymmetry and aorta appear very small. Rhabdomyomas, though easy to diagnose, may appear only in the 3rd trimester. And when we have any tumors in the heart, we should definitely look in the head for association of tuberous sclerosis. Skeletal anomalies like achondroplasia can be suspected in the 2nd trimester scan when we get a short femur, but then we need to follow up and they may be confirmed only in the 3rd trimester. This is frontal bossing. This is rhizomelic and bowed femurs. And this is improper mineralization of the spine. This is talipus feet. It may manifest later, especially in oligohydramnios, and when diagnosis becomes difficult. In face and neck, though we can diagnose cleft lip, cleft palate in the 1st trimester, but many compromised imaging, especially in oligohydramnios, can lead to a misdiagnosis of cleft lip and palate, and so it may first appear to us in the 3rd trimester. Here is the cleft. This is a cervical lymphangioma, which can manifest later, and these are bilateral dacryocystoceles, which can appear only in the 3rd trimester. While diaphragmatic hernias can again be diagnosed in the 1st trimester, but this study reported a diaphragmatic hernia in the 3rd trimester. Now, the diagnosis of diaphragmatic hernia is best done in the sagittal section. We are seeing the diaphragm continuous through and through, and the cystic structure is lying not below, but above the diaphragm next to the heart. So this is the stomach, and this is the diaphragmatic hernia, we are for sure. While taking axial sections, we should be very careful because the rib on the either side should be continuous and not broken, because broken ribs may show axial sections which are taken transversely and may lead to a false diagnosis of diaphragmatic hernia. In gastrointestinal tract, small bowel obstructions, tracheoesophageal atresias, meconium peritonitis, and abdominal cysts can appear in the 3rd trimester. These are images of jejunal and ileal intestinal obstruction, and this is the double bullseye of duodenal atresia. Large bowel obstruction, though, can be doubted in the 3rd trimester, but cannot be confirmed until postnatally. Tumors like lymphangiomas and secrococcygeal teratomas can also manifest in the 3rd trimester. So combining data from 13 studies and over 140,000 women, it showed that during routine 3rd trimester ultrasound, an incidental fetal anomaly will be found in only about 1 in 300 scanned women. In low-risk patients, fetal karyotyping in the 3rd trimester may be justified, and 2 or more anomalies increase the risk of fetal aneuploidy from 2% to 21%, even with a negative screening test in the 1st and 2nd trimester. These, though polydactyly and imperforate INS, are anomalies diagnosed by the external machines and are adept phonologists throughout the country, but still they remain a diagnosis of postnatal evaluation. This, I would like to share 2 cases with you, which we had recently done. This was a 17-week scan done for this patient, and the cerebellum is looking intact with no keyhole in between. The BPD was 42, so CSP was not seen, was not my criteria, because CSP is evaluated between 44 and 88 mm diameter, and but the nasal bridge was depressed. So we called this patient for a review, and what we saw was a nightmare. We saw typical colpocephaly. Frontal horns were notched, pinched out, and occipital horns were dilated. Third ventricle was pulled up. This was agenesis of corpus callosum with a keyhole-shaped sign. And this is the keyhole with a net image that I tried to show. And this is the binder's faces that we saw in the patient. There is another patient referred to me for ventriculomegaly, and when we examined the patient, there was talipus, there was a sacral meningocele which was not picked up and which was seen on a 3D scan, and there was horseshoe kidney. So there were multiple anomalies in the 3rd trimester scan, but in the 2nd trimester scan, there was only ventriculomegaly. So ensuring appropriate consent prior to a growth scan is important. Anxiety can be provoked given the limited time to carry out full investigations. Referral for appropriate fetal and neonatal care should be done, and implications at the level of health system, such as the need for an efficient late referral pathway and associated cause of growth screening, should be discussed. Even late diagnosis of an abnormality will allow parents to prepare the birth of a baby with an anomaly, timely in utero transfer, and guide appropriate follow-up of the newborn and infant. These are my thank you for a very patient hearing.
Is Dr. Rekha there?
Yeah, I'm there.
Yeah, please, your comments.
Yeah, very good presentation, Dr. Shika. Yeah, as you have told, many of the times it is a second trimester scan we consider as obstetrician gynecologists. That is a scan is equal to anomaly scan, and we consider the third scan is that the third trimester scan is a growth scan. That is what is the name that is given, and that's how we go usually. But there are many times where we detect the anomaly for the first time in the third trimester. We should keep our third eye open to detect these, though most of the times the anomalies, especially the lethal anomalies or the major malformations, are invariably detected in the second trimester. This may be a very small percentage, as you have mentioned, that we detect in the later trimester. That too, because we have kept an open eye on that and we are very vigilant to detect, or sometimes it might have evolved, which was not there, say ventriculomegaly or hydronephrosis, whatever, which was not there, that has come later. Again, there is one more problem, that the detecting person, that is a sonologist, sometimes though it is there in the early scan itself, might not have detected. The problem with the sonologist, the machine, in a small centers, or sometimes it may be because of the problems on the patient side, in the sense obese patient, multiple pregnancy, or oligohydramnios. So these are the things, those can be added. This is all what I want to say.
Chika, please stop sharing so we can have the discussion.
Yeah, correct.
Just one thing I thought, if Alka is there, when we say ovarian cyst, Shikha, we say ovarian cyst, the cystic structure, probably ovarian, and immediately patient gets to know, obviously, that it's a female child, female fetus. Is that okay? Because I did face this problem in 2 patients. They said ovarian cyst, and then patient immediately jumped and said, of course, not with a negative attitude, but at the same time, we are so very worried about PCP and DT all the time. But towards, of course, this is in the closer to beyond second trimester. But when you say ovarian, you commit to the female fetus. So if Alka is there,
Ma'am, we mention it as a gonadal cyst and not as an ovarian cyst. Yes. That is not permitted. You mention it as a gonadal cyst.
No, but the ultrasound report which I had received mentioned it likely.
This is not. This is not correct. This is not.
Then if you are going to mention as gonadal cyst or pelvic cyst or something, then that's fine.
And we give a DD usually with a gonadal cyst. It could be a mesenteric cyst.
Mesenteric, yes.
It could be any other abdominal cyst. So we give a DD with the gonadal cyst. We don't make it very obvious. It is a good.
Thank you, Shikha, for a nice deliberation. And one should know that we have done second trimester, we have done first trimester screening, but then there are a huge number of cases that come out in the third trimester itself. So, हमने second trimester we have done, and we justified that all the anomaly scan has been done. Now your baby is all right. Or at the end, when the baby delivers, he succumbs because of a congenital heart defect. I have seen this type of a case. So third trimesters can according to your Shika, according to the recommendations, do you recommend it in the third trimester? Full anomaly scan?
Ma'am, I don't believe third trimester could be a growth scan.
We are doing growth scan in that third trimester.
I do an anomaly
but
scan
then
comes to me.
Yeah, but what I have heard from all the sonologists, that any sonography which is being done should be done with an open eye for everything, not only growth. Of course, you have referred for growth, but the sonologist who is doing the growth scan should have an open eye to see all these things. And this 3 by 1,000 cases, 3.9 by 1,000 cases is not less. And whenever you get this type of cases, you are in a problem. So once you have diagnosed in the third trimester, you know what to do, where to refer, how to deliver, where to deliver, and what postnatal care and investigations to be done. In this case, you may discuss with the pediatrician, with the fetal medicine person, and then you show the right path to the patient. That is the most important thing. Nothing else we can do. The most common varieties are the urogenital tract anomalies. Then comes the central nervous anomalies, and then the most dreaded ones are the heart anomalies. And these cases do come. You know that the patient is all right, the baby is all right, anomaly scan is normal, सब कुछ ठीक है, growth भी अच्छा है. You deliver the baby, do a cesarean, third day the baby is off. So you, if you know it prior, then you tell the patients properly, and that baby to be delivered in a higher center. So and the parents also know that what they have to do next. Postnatal phase में भी मुझे बहुत कुछ करना है. If the patient know and the counseling has been done, then you are safe. And this is very, very important that whatever growth scan is being done, that should include anomaly also.
Even if you tell the patient an anomaly in the third trimester, then also he is convinced that you told it before. So,
and if we tell them and we prepare them, they are also prepared mentally what to do next.
Absolutely.
This is the most important point.
Thank you. Shikha, Dr. Shikha, a wonderful lecture delivered by you. And because of the blessings of our boss at South Chennai.
Mediscan, Dr. Indrani and Dr. Suresh, they have got me personally.
Yeah, that's
and I'm adept, and like I'm indebted to them throughout my life for the.
That's why we are lucky that you.
Ma'am, I'm very lucky I got it there, and then sir and madam used to take special care that this girl is from north, so we should, like, she's come from such a far distance, she should learn something. So they used to analyze my images separately, ma'am. So I am like indebted to them for whatever they have done for me.
I wanted to comment, ma'am. What you said, gonadal cyst, that is a correct term because you cannot say ovarian cyst. You have to correct it. Yeah. Secondly, I have seen 2-3 patients in my last 5-10 years. They had hydrocephalus. It was never diagnosed before. They
There are so many patients.
It can happen, ma'am. It can happen.
Yes, it comes out in the third trimester.
Ma'am, it can happen. It can be an occulta spina occulta also, ma'am. It can be an open spinal defect. Like I showed you, the sectional meningeal seal was not diagnosed before. Only ventriculometry was diagnosed. When we did a 3D and when we did a follow-up, then only we could see that sacral meningeal seal. So it is very...
All the messages that all the obstetricians should know what to comment to the patient when they bring this type of a report, and they have been under supervision of an obstetrician who has got all the screening tests done before. ये हमको नहीं कमेंट करना है कि पता नहीं कैसे देखा नहीं. Everybody should know what are the anomalies that can be caught in the third trimester, what is its incidence, so that we can counsel the patient properly, and we don't go against the ethics against our brothers and sisters.
What message I wanted to give? Many patients we advise NT scan, then anomaly scan. So sometimes there are patients who, in spite of advice, they don't go undergo all these scans. When she comes for the first time in third trimester, I have already written there, advice NT scan, advice anomaly scan. First sentence I write there, though it was advised by me, patient has not undergone all these tests, and take her signature because it is informed.
What I write on my prescriptions, first visit to my clinic.
Yes.
And secondly,
documentation is absolutely necessary, ma'am. You document, you have advised NIPT, amniocentesis. You document, you have advised a double marker. You have advised a quadruple marker. Patient refused. I advised your first trimester scan, patient refused. Advised second trimester scan, patient refused. You document it properly in your papers. No one can touch you. No one can touch. Documentation is absolutely essential, ma'am.
Second thing, what I wanted to stress upon, even if she has not undergone any sonography till death, this is the last trimester, still we should write all these things that she has not done.
That should be written. Yeah.
So no, the problem about Shikha, Reena ji, what we have in clinical practice, yes, we advise they neither refuse nor get it done because they have to go went to their, like now unko ek mahine time nahi mila.
They come after 3 months, no problem. After whatever date you have written for the visit, that is showing that the patient was not concerned. They didn't come at that particular time. और ये पेशेंट को मैं बता भी देती हूँ कि इस समय एक बहुत जरूरी जांच होनी थी, आप नहीं आए, चलिए आप ये वाला करा लीजिए. But don't panic. Panic नहीं करना.
Better late than never. It is better late than never.
Yeah.
So at least advise then and that
whatever is left in our hands at that particular time, we should offer and then write. This is the first visit to my clinic. The patient has not attended, and now these are the advices. ये तो मैं पूरा लिख देती हूँ.
She has not undergone all these tests. No, she is coming for the first time to me. Ultrasound. Maybe growth scan is there, but again, radiologist perform everything because he has to say everything because no scan till death. So anomaly scan is not exception of the particular. It can be done anytime. So even if that time was seen, we have to inform to the patient that it was the first time was seen.
और ये all quadruple and anomaly scan हमको ये बोलना पड़ेगा कि कुछ चीजें बाद में ही पता चलती हैं because always they say सब कुछ हुआ because we see patient की उन्होंने सब चीज कराई और patient था then we have to be कि कुछ चीजें बाद में ही पता as the baby grows then we come to know because so Dr. Kamani आप perspective trimester
नमस्कार
आप हम लोगों से क्या चाहते हैं जब हम वो बच्चे डिलीवर
मैडम थैंक यू फॉर द giving chance to have some comment. Thank you Shikha you for a good and vast deliberation. मैं ये कहना चाहता हूँ एज ए पीडियाट्रिशियन कि अगर हम थर्ड ट्राइमेस्टर में लेबर रूम में या ओटी में रहते हैं और हमको पहले से कुछ एनॉमलीज मालूम रहती है तो हम अपने आप को भी मेंटल प्रिपेयर करते हैं कि हमको क्या क्या तैयारी करनी है. स्पेशली अगर डायफ्रामेटिक हर्निया है तो हम पहले से मेंटल प्रिपेयर करेंगे कि उसको अम्बू हम नहीं यूज करेंगे ड्यूरिंग टाइम ऑफ रिवाइवल. रिसस्टेशन में हम अम्बू नहीं यूज करेंगे. हम अपने आप को मेंटली प्रिपेयर किए रहते हैं. और भी बहुत सारे स्पेशली कार्डियोवास्कुलर एनॉमलीज के लिए अगर हम पहले से हमको मालूम है या ऑब्स्टेट्रिशियन को भी मालूम है तो वी कैन प्लान for delivery at a higher center where all these modalities are available to deal with. इस क्योंकि अगर एक बार पैदा होने के बाद बच्चे को अगर ट्रांसफर करते हैं हायर सेंटर पे तो वो बहुत ही एक फाइनेंशियल बर्डन भी हो जाता है पेरेंट्स को इन स्पाइट ऑफ ऑल साइकोलॉजिकल बर्डन. क्योंकि वो चाहता तो है बहुत सारे पेरेंट्स अफोर्ड भी कर पाते हैं लेकिन उनको शिफ्ट करने में भी बहुत प्रॉब्लम होती है स्पेशली मेजर आर्टरी एनॉमलीज एंड great transposition of great aorta and especially such. और अगर सेंट्रल नर्वस सिस्टम का एनॉमलीज देखें और स्पेशली स्ट्रक्चरल डिफेक्ट देखें तो हमको पहले से पेरेंट्स को भी कन्विंस करना पड़ता है और हमको भी बताना पड़ता है कि आपके रिपोर्ट में ये सब चीजें हैं, देयर में बी सम प्रॉब्लम. तो उसको मेंटल प्रिपेयर करने में भी हम भी एक सहायता करते हैं और स्पेशली बाद में तो हमसे भी बहुत खोजबीन होती है. अगर ऐसी प्रॉब्लम होती है तो ऑब्स्टेट्रिशियन के लिए भी बहुत सारी हमसे खोजबीन होती है कि डॉक्टर साहब ऐसा क्यों हो गया, पहले क्यों नहीं पता चला. तो हमको भी बहुत ही अटेंटिव रहना पड़ता है कि मेरे मुंह से कुछ भी एब्सर्ड या कुछ भी ऐसी बात ना निकल जाए गलती से भी. तो वो सारी बातें हम पहले से अगर जानते हैं तो अपने आप को भी मेंटली प्रिपेयर करते हैं और पेरेंट्स को भी प्रिपेयर करते हैं कि आपके बच्चे में प्रॉब्लम है. कुछ प्रॉब्लम तो ऐसी है तो कि पोस्ट नेटल ही पता चलती है, स्पेशली अगर टेलपीज है या वो है तो वो तो कुछ चीजें ऐसी है जो कि आसानी से या जल्दी ट्रीट हो जाती हैं, मतलब उनको आसानी से किया जा सकता है. और नर्वस सिस्टम के उसमें मतलब अगर हाइड्रोकेफेलस है, डैंडी वॉकर सिंड्रोम है. अब डैंडी वॉकर सिंड्रोम पहले से मालूम है तो उसमें डेवलपमेंटल डिलेज होते हैं तो उसको पहले से अगर हम हैं तो हम वॉचफुल रहेंगे. पेरेंट को भी हम बता देंगे कि देखो भाई तुम्हारी रिपोर्ट में ऐसी बातें हैं, हो सकता है कि लेबर रूम में या पोस्टनेटल कोई प्रॉब्लम या कोई सिम्प्टोमेटिक इफेक्ट ना आए. इसलिए कुछ डिफेक्ट्स में इमीडिएट प्रेजेंटेशन नहीं होता, लेट प्रेजेंटेशन होता है. तो अगर ऐसा फॉलोअप में भी हमको मालूम है कि इसके रिपोर्ट में ये सारी प्रॉब्लम थी तो उसको फर्दर इन्वेस्टिगेट करते हैं. ऐसे ही अगर यूरोलॉजी से संबंधित चीजें हैं तो उसको फर्दर पोस्टनेटल, जैसा कि शिखा ने भी कहा कि 3rd डे फिर 7th डे स्कैन करें, फिर अगर फर्दर उसमें रहता है, अगर हाइड्रोनेफ्रोसिस है, अगर कई बार तो एंटीनेटल हाइड्रोनेफ्रोसिस होता है, लेकिन अगर हम लोग पहले बाद में स्कैन करते हैं तो उसमें मोस्ट ऑफ द केसेज में पता चलता है कि हाइड्रोनेफ्रोसिस रिसीड कर रहा है। तो ऐसी सिचुएशन में हम लोग वॉचफुल रहते हैं। बाकी तो every anomalies cannot be detected by any means, as पिछले 2.5-3 घंटे से डिस्कशन चल रहा है।
Sir, 50% renal pyeloctasis will resolve, 25% will remain static, and only 25% will deteriorate. तो 50% cases will
कोई विजया का सवाल था ना, percentage is percentage, and that makes really thing very complex today, really complexity of pattern obstetrics. So obstetrician and the pediatrician, thank you Dr. Kamani that you will not say anything adverse for us. That could detect. Thank you. We need such pediatrician also.
Yeah, I know.
Because
as Dr. Sunil says, pregnancy के time पे थोड़ा सा that dialogue between the obstetricians and the pediatrician is important. In fact, in our institution, if there is an anomaly, a sizable anomaly or something which we come across, and anyway patient is continuing with the pregnancy, then we do send them for one referral this thing to the pediatrician who's going to handle, or the
that is what I said.
Because that gives us very good comfort, so that just after delivery we don't get into across the line this side and that side, because that's usually the problem. So I think pediatrician is sounded enough. No, pediatrician is also prepared how to, so they also are able to help us by saying, okay, this is how the child is going to be. So I think
not crushed between patient and neonatologist, poor obstetricians.
Sadhna madam, it's not a question.
Yes, it could recede, और कई बार होता है बच्चा normal था, आपने इतना परेशान किया.
नहीं तो we should be able to counsel them.
मेरे को दौड़ाया, so ना.
Answer to counseling
percentage of what Vijaya says, the percentage actually makes us very.
Yes, Alka. And no loose lines for your fellows like pediatricians or radiologists. उसमें ठीक से नहीं देखा, उसने ठीक से नहीं किया. This all should be known. जितने भी ये cases होते हैं, some or other of we only must have given a wrong statement.
Exactly. We only.
One thing I wanted to highlight, ma'am, when the patient brings sonography report with me that she is having renal pelvis dilatation of the baby, or some diaphragmatic hernia is there. There is one super specialty hospital in our city. So we refer the antenatal case to that surgeon,
yes,
surgeon.
That should be. That should be.
They are there at the time of delivery. They carry the baby to the hospital. Sometimes it is immediately performed. Sometimes it is day 3 of the baby.
So even diaphragmatic hernias and
one opinion from pediatricians.
That is the practical importance that we like organize for immediate postnatal care. Actually, that is the thing which is leading forward.
Should not be hesitant in transferring.
Couple, they get ready for this also because they are already communicated by the pediatric surgeon.
Yes.
When the baby will get delivered, I will be there to receive the baby. So he is already there. We give phone call that cesarean कर रहे हैं हम लोग. वो आ जाते हैं, baby को लेके जाते हैं. So what is
we always do a cesarean with the pediatrician.
Improve the outcome also.
ऐसे तो
Patients
करते
are
नहीं.
believe in us. कि भाई मैडम ने पूरा पहले सिस्टम अरेंज की है. That he is ready to receive the baby. So this all these things.
एक चीज में और I will like to add that like especially in the 3rd trimester, and like delivery, the communication between pediatric surgeon, because we are not knowing what are the advances in the pediatric surgery, what are advances in neurosurgery. So in antenatal period communication, because we had a wonderful oration, how many babies have got that outcome, and finally with the so this is also important.
Even the exit procedures they have done.
You know everything about how to operate, when to operate.
Can be done nowadays. So I think
try and transfer.
So they put a balloon in the trachea and that inflates the lungs. So all that is in the cavity is pushed down. So this is being done outside, but not in India for now.
It depends upon the place to place. Like Delhi, Pune, Bombay, there are many advanced things for the babies. Suppose in a city like Amravati, where I stay, there are some limited facilities, suppose. So we can advise refer the patient. With in utero also we can transfer the antenatal case. But if the patient is ready to receive the baby that time, then we can keep the mother here only. So it facilitates our this thing, na? Referral procedure also.
And also the intrauterine procedures by ultrasound guidance. Dr. Suresh does the for the hydrocephalus, the peritoneal shunts, ventriculoperitoneal shunts and all they are putting. So I think it's very important that we really are
aware of what is happening around.
Yes, correction of posterior urethral valve.
Beginning of my practice, I had one hydrocephalus ANC. I tapped the hydrocephalus and delivered vaginally. But there was still mild degree. So what the patient said, I want to take the baby to Pune. I told prognosis and everything because it was long term, long standing. So everything was because of compression of the fluid. But she said,
may I be excused?
I want that chance also to save the baby. So she took the baby to Pune.
Thank you, Sadhna ma'am. Thank you.
Any amount.
Yeah. Thank you.
So can we leave now?
Yeah, I think so.
Conclude session, Babita or Aruna.
Thank you. किसको करना है बोलो?
We have no question answers. All the question answers have been discussed during the talk. So we have no questions in the chat box. Now,
Thank you, Sadhna madam.
Vote of thanks.
Thank you, Sadhna ma'am, and thank you the organizing committee for giving me this opportunity. Thanks a lot.
Thank you so much.
You're very good. All the speakers very good. And I'm stimulated so much of discussion. A vote of thanks, Tumara.
Very unique webinar, madam. It a lot of points, practical points on ultrasound. Very, very unique webinar I felt, because otherwise many practical regular obstetrics and all. It looked very nice. Almost the entire ultrasound you covered.
Yeah, what to do.
Very good selection of cases. Topics.
Topics
were really, we really had to work for these topics.
Especially no one would have thought of the last topic.
Yes, ma'am. And I was in a marriage when ma'am called me for this. And then I searched papers and papers were not, some journals were not opening. And I worked for them. And it took me time to actually get across all that.
Thank you.
Because
Normally by 28 weeks. We can thank each other and I think that's enough.
Thank you, madam.
Thank you, ma'am. Thank you once again.
Thank you कर दिया.
It's my pleasure.
Aruna को thank you करना है ना? जल्दी करो.
मैं thank you. Good evening, respected dignitaries and all the audience. I deem it a great honor to propose vote of thanks to all for making this webinar a resounding success. First of all, I would like to congratulate Dr. Sadhna ma'am for organizing this webinar. An event of this dimension cannot happen overnight, but everything is possible for Sadhna ma'am. My gratitude to Dr. Gangadhar Sao, our chief guest, for gracing the occasion and blessing us. Sir, your kind words warmed our hearts. Regards to our torchbearer, Dr. Usha Sharma ma'am, our special guest. We are all inspired by your highly sparkling words. I would like to express my profound gratitude to Dr. Pragya Mishra, our guest of honor. Ma'am, we are deeply humbled and honored by your encouragement towards us. I would like to thank our distinguished speakers, Dr. Moni, Dr. Deepti, and Dr. Shikha. The presentation was very excellent, and today we had very, very interesting and good discussion that we never ever had. I'm running short of words to express my humble thanks to our experts, Dr. Sukanta, Dr. Mala, Dr. Amrita, Dr. Sadhna ma'am, Dr. Vijay Lakshmi, Dr. Alka, Dr. Rekha, Dr. Reena ma'am, and Dr. Sunil Kamani sir for their valuable inputs and making a healthy discussion. My special thanks to my co-moderator, Dr. Babita, and I would like to place my hearty thanks to all the participants whose presence always encourage us to do more. Your gracious presence add vibrancy to the entire session. My generous thanks to the dedicated Corona Remedies for the smooth flowing of the webinar. Once again, thank you all.
And thank you to the moderators.
Thank you.
Bye, everybody.
Bye bye with both hands. Bye 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 bye.